pharmacological therapy will help better than a pharmacological therapy. So if you look at it, this is a point to ponder, because when we have patients with symptoms, despite achieving biochemical euthyroidism, what do we do? Do we go in for a T3 or do we go for psychological therapies? There we need to differentiate between the actual low T3, low tissue T3, or if the patient is having a type D personality, which may be a little difficult, but probably we can use the questionnaires which are being used and then probably figure out what this patient is in need of, rather than blindly treating people with leothyroid, because there should be sort of correct, or there should not be overuse or misuse of leothyronin, because there is this background type D personality which may be at play. So if you look at MNYES, if that is the true elephant in the room, then the low tissue T3 is a mouse in the room. And when we want to make a diagnosis and treat the patient, probably we'll have to have an unbiased consideration of both the elephant and the mouse, I would say. Now let's go on to hyperthyroidism. So if you look at hyperthyroidism therapy, we know that we give medical management and then we look at the TRAB levels. And if the TRAB levels are high, which means that it will help us decide whether this patient is going to be continued on medical management or definitive therapy has to be given. So the TRAB levels sort of tell us or help us in making a decision. So, and as we all know that Graves' disease, as this is an autoimmune disorder, so whether immunosuppressive therapy could have an effect on the TRAB level and thereby have an effect on the remission rate. So this is the context behind this particular study, that is effect of low-dose methotrexate with methimazole in patients with Graves' disease. This was a Chinese study and a randomized clinical trial. So if you look at this, so supplemental methotrexate based on these immunomodulatory effects may affect the clinical course of Graves' disease. So the objective of this study was to evaluate the efficacy of add-on methotrexate on the medical treatment in Graves' disease. So this was a prospective open-label randomized supplementation control trial. And this was about 153 untreated hyperthyroid patients who had Graves' disease. And they were randomized into receiving methotrexate 10 milligram per week with methimazole, or only methimazole. And methotrexate and methimazole were discontinued at months 12 to 18 in euthyroid patients. So the main outcome measure was what was the discontinuation rate at month 18 in each group. So if you look at this, we can see that at month 18, there was a statistically significant adherence in efficacy. At the discontinuation rate was about 55%. So you can see here that at 12 months, 15 months, and 18 months, we see that the rate of discontinuation of medication was much higher in the methotrexate plus methimazole group as compared to only the methimazole group. And if you look at this particular slide here, we see the TRAB levels. So in methotrexate plus methimazole group, the TRAB levels are much lower. So you can see the line here. So these are much lower compared to the only methimazole group. This again implies the immunomodulatory effect of methotrexate. And at the end of 18 months, again, we see that the TRAB levels were much lower in the methotrexate plus methimazole group. There was not much significant difference in the thyroid hormone levels as well as in the cumulative methimazole dose in both the groups. So treatment of patients with Graves' disease with this novel combination therapy consisting of methotrexate and methimazole, it resulted in a higher discontinuation rate and an improvement in the TRAB levels to better levels faster than the methimazole alone. So this was a study which was done for about 18 months. So we know the effect of methotrexate at 18 months, but we do not know the long-term remission status. So as of now, we have data only for 18 months. Probably following up these patients would give us better idea about the use of methotrexate plus methimazole in patients with Graves' disease. Going on to another modality of treatment of Graves' disease. So this is a Japanese study which has looked at the efficacy and safety of ultrasound-guided thermal ablation of Graves' disease. So this was a retrospective cohort study. And in this, about 50 Graves' disease patients who were treated with thermal ablation between October 2017 and December 2021 were included. And in this particular study, after this thermal ablation, so the thermal ablation can be done either by microwave ablation or the radio frequency ablation. So they have used both these modalities in this particular study, depending on the availability. And key metrics like the thyroid volume, the volume reduction rate, and thyroid hormones were evaluated at the end of this particular study. And they were followed up for 1, 3, 6, and 12 months after the thermal ablation. So if you see here, the volume of the thyroid is reducing over the months. So at the end of 12 months, there was a significant reduction in the volume of the thyroid gland. And if you look at the volume reduction ratio, that is a percentage of reduction in the thyroid volume, again, this percentage is high at 12 months. So it means that they have a significant effect on the thyroid volume. And by 1 year, the TSH levels had normalized and it had come to about 3. The mean value was about 3. But despite the excellent short-term efficacy, the long-term efficacy is not known. And the TRAB levels, if you look at it, there was an initial surge at 1 month, followed by a fall at the end of the study. So if you look at surgical thyroidectomy versus thermal ablation, this seems to have an advantage because the complications of thyroidectomy, like recurrent laryngeal nerve palsy, was not seen in these patients. Only very minimal side effects were seen. This is also aesthetically better. So this probably in the future has a role to play in patients with Graves' disease. And going on to the next article on hyperthyroidism. Now we know that teprotumumab is approved for treatment of thyroid eye disease. So ever since teprotumumab has been used, there have been case reports and case series on audiometric abnormalities. So hearing abnormalities in patients who had used teprotumumab. So this was a prospective study which has examined the audiometric outcomes following teprotumumab treatment for thyroid eye disease. This was from the US. So in this, if you see, there were about 52 patients who were enrolled in this study, predominantly females. At baseline, the audiometry showed normal hearing in 32 patients and abnormal hearing in 20 patients. And after the 8 infusions of teprotumumab, at 24 weeks, one patient in the normal hearing group developed significant hearing dysfunction, which persisted 6 months post the infusions. And in the abnormal hearing group, about 9 developed worsening of the hearing dysfunction. And this persisted. About 4 patients had persistence of this hearing dysfunction at 6 months. So why is this important? Because when we block the IGF-1 receptor, we're also going to block IGF-1 receptor in other organs, not only in the eyes, because IGF-1R expression is also present in the cochlear, especially in the inner ear, in the cochlear nerve. And this blue area is the places where the IGF-1R is expressed. And this is important because IGF-1R signaling is important for the normal inner ear and the eustachian tube function. So if you look at this here, this pad of fat, the Ostman adipose pad, again, it depends on the IGF-1R signaling. So when this is blocked, there is dysfunction of this adipose pad, which can lead to a patulous eustachian tube. So these are the reasons as to why they could have otological abnormalities in patients who have used teprotumumab. So when we get to use it in India, probably these are side effects which we should be looking out for. So that brings us to the end of hyperthyroidism. Let me move on to thyroid malignancy. So this, the estimable 2 trial we've already discussed, and this was a 3-year data was already presented and published, and which also had a role to play in the guidelines, because now radioiodine is not advised for everybody. So you can still do without radioiodine after thyroidectomy in patients with low-risk thyroid CA. So this is the 5-year follow-up data of the same trial. So the previous trial had shown non-inferiority or of a follow-up strategy, that is only thyroidectomy with no radioiodine in low-risk patients. So this objective of this particular trial, which was published, was to report the 5-year follow-up data. And this was a multi-center randomized phase 3 trial. So patients who were treated with total thyroidectomy with or without prophylactic neck lymph node dissection, without any post-operative suspicious findings on neck ultrasound, they were randomly assigned to the no radioiodine group or to the radioiodine group. And they were followed up to look for functional, structural, or biological event. So these events, basically, they mean if there was any iodine 131 foci uptake outside the thyroid bed, or if there was any remnant in the thyroid, or if there was an increase in the TG or the anti-TG. So this was what was looked for in the follow-up of these patients. And it was found that of the 776 patients who were enrolled, 698 were evaluated at 5 years. So the proportion of patients without events were 93% in the no radioiodine group and 94% in the radioiodine group. So the difference was not significant. And mostly it was biological abnormality, that is TG, anti-TG abnormality, which was found in these particular patients. If you see here, so this is the circles represent the patients without events with radioactive iodine and without radioactive iodine, and the difference is not very significant. So the interpretation of this particular study, so it shows the non-inferiority of a follow-up strategy compared with post-operative iodine 131 administration in low-risk differentiated thyroid cancer. So this, again, something else has to be kept in mind. It is not only, it's not a blanket rule for everybody with low-risk thyroid CA. We'll have to consider the age, look at the size of the tumor, because the bigger the size of the tumor, the greater the incidence of recurrence. So we'll have to look at all of this and then take a decision about giving radioiodine in low-risk thyroid CA. So since we are in the GLP-1 RA era, let's also have a look at this particular question. So GLP-1 RA and thyroid cancer, is there a risk? Because there have been many case reports, case studies, RCTs, which have shown that there is an increased risk. But there have been 2 meta-analyses which have been published in the last year. So this one has shown that the glucagon-like peptide receptor agonist and risk of thyroid cancer in an international multi-site cohort study, which was an international cohort study. We have utilized databases from Canada, Denmark, Norway, Sweden, South Korea, and Taiwan. And here, actually, patients who were on GLP-1 RAs were compared with those initiating DPP-4 inhibitors, and the primary outcome was an incident thyroid cancer diagnosis. The median follow-up of the GLP-1 RA cohorts was about 1.8 to 3 years, whereas DPP-4 inhibitors were about 2.8 to 6 years. So in this cohort, what was shown that the GLP-1 RA users were not associated with an increased risk of thyroid cancer. And when they looked at the cumulative dose, again, there was no trend in the increase in the risk with increasing cumulative doses of GLP-1 RA. On the other hand, we had this particular meta-analysis, which was showing a conflicting result. So here, there was no comparator. It was only GLP-1 RA in the RCTs. So they found that of the 86 cases of thyroid cancer which were retrieved, a majority of them was in the GLP-1 RA arm, and many of them were in fact PTCs, papillary thyroid cancer. So this is what is the take-home message, because this particular study had a low fragility index, which means that the thyroid cancer incidence in this particular cohort, if you see, it's very low. So even addition of one more patient in the comparator arm would have made the results insignificant. So probably we need longer term studies, and that is why the FDA has constituted a registry. So these patients who are on GLP-1 RAs have to be followed up for 15 years. So this 15-year data will give us a better idea about the risk of GLP-1 RA and thyroid cancer. So this is the last study that I'm going to be talking about AI in thyroid nodule diagnosis and management. So here, this is again a very interesting study, because as we know, the first step that is in management of or in the diagnosis of thyroid nodule would be an ultrasound, which is heavily operator dependent. There are a lot of inter-individual variations in reporting. So they have, in this particular study, they have taken the database, the data set of about 19,000 images of patients, and they have developed algorithms, about 17 algorithms, out of which they chose one, and again applied it to an external validation set, another set of patients and images. And again, this was again validated in another set of patients. So this thyroid AI, so AI thyroid assistance, the secondary outcome was what was very interesting, because they used this AI thyroid to see if there is an improvement in the sensitivity and specificity of reporting among physicians. So they have taken 6 radiologists. 4 of them were residents, so basically less experienced, and 2 faculty. And they found that the sensitivity in the trainee increased from 84% to 92% when they used an AI-assisted model, and the specificity increased from 72% to 86% with an AI-assisted model, which again is a good thing because there's a lot of inter-individual variation in ultrasound reporting. So especially in inexperienced hands, this AI may help us to decide correctly which are the nodules to be sent for FNA. So if you see here again, with AI, without AI, the true malignant, true malignant increases, the true benign increases, and the false benign and the false malignant have come down. Again, this is a model which has to be worked on more. And if this model could be developed to also look at the indeterminate nodules where we actually need the help, it would be better. So these are a few other guidelines. I'm not going into the details of these. So the 2024 European Thyroid Association Guidelines on Diagnosis and Management of Genetic Disorders of Thyroid Hormone Transport, Metabolism and Action. The residents, if they're there, they could probably read through this. And we do have some consensus statement from the Indian Thyroid Society on the diagnosis and management of thyroid nodules, and consensus on the salt iodization as well. So these are very good reading material which the residents can go through. So to summarize, I've talked about the need for patient-specific TSH cutoffs, type T personality and hypothyroidism, where we need to consider pharmacological versus psychological therapy, immunosuppressives in Graves' disease, and ultrasound-guided thermal ablation in Graves' disease, hearing abnormalities in teprotumumab users, and thyroidectomy without radioactive iodine in low-risk patients, the outcomes, the 5-year outcomes. I've also talked about the GLP-1 RA and thyroid cancer and use of AI in thyroid nodules. So thank you all for patient listening, and thank you, Indian Thyroid Society, for the opportunity.
Thank you, Dr. Beatrice. It was a beautiful presentation. You have summarized the updates in thyroidology over the last 1 year.
Thank you, Madam, for going through all the latest papers and summarizing it so well. I also extend my gratitude to the chairpersons, Dr. Jo Sir and Dr. Kumaravel sir, for excellently moderating the session. So with the chairperson's permission, shall we move on to the next?
Yes, you can go ahead.
Yes, sir. So we shall now move to a panel discussion on a very controversial topic, that is subclinical thyroid disorders. There always has been a dilemma to treat or not treat hypo or hypothyroidism, which is subclinical. We have a very distinguished panelist and moderator, Dr. Sara Alam, who will be discussing those unanswered questions. So, Dr. Sara is the specialist endocrinologist and deputy medical director of Canadian Specialist Hospital at Dubai, who graciously agreed to be the moderator. So, I now request Dr. Sara to introduce our distinguished panelists.
Hello, good evening, everyone. Hope everybody is able to hear me.
Yes, we are able to hear you.
Yeah. So it's my absolute pleasure to be here moderating this session. And it's my honor to introduce our esteemed panelists. I will start with Dr. Shashank Joshi, who is current affiliation is endocrinologist, diabetologist, and medical researcher, one of the most prominent medical experts in India. He's honored by the government of India by awarding him the Padma Shri in 2014. He was a part of COVID-19 task force for the state of Maharashtra. He's a chair, International Diabetes Federation, Southeast Asia, past dean, Indian College of Physicians, and he was also featured in Prime Minister's Mann Ki Baat radio show in April 2021. And also you can see him on a lot of TV channels where he's invited as an esteemed guest. Then our second panelist would be Dr. Mini Pille, who is consultant endocrinologist, Lakshmi Hospital, Ernakulam. She is treasurer of Indian Thyroid Society. previously president of Central Kerala Endocrine Society. She has several publications, 3 international, 12 national, 3 textbook chapter. Our next esteemed panelist is Dr. Sujoy Ghosh, who is Professor of Endocrinology at IPGMER, Kolkata. He is DM Endocrinology, FRCP London, Glasgow, Edinburgh, FACE, Specialty Certificate Endocrinology and Diabetes UK, FICP. He was awarded International Clinician of the Year 2021 by the American Association of Clinical Endocrinology, WIDF Award for Innovation in Diabetes 2021, International Advisory Board Member, Endocrinology Section, Davidson Textbook of Internal Medicine. Then our last but not the least, our panelist is Dr. Saptarshi Bhattacharya, who is a senior consultant endocrinology Indraprastha Apollo Hospital, New Delhi. He's MD from MAMC, DM AIMS, FACE, Specialty Certificate UK, ex-secretary CEPHIS, executive committee member Endocrine Society of India, Indian Thyroid Society, honorary secretary Endocrine Society Delhi, and ex-president of SPEED. So let us begin this very important topic, which is subclinical thyroid disorders we will be discussing today. So without wasting further time, I would like to ask my first question from Dr. Mini Pille. What are the clinical features of subclinical hypothyroidism and when should we treat it? This is a common question which we face every day in our clinics. So I would like to hand over to Dr. Mini Pille.
Yeah, thank you and good evening all. Basically, subclinical hypothyroidism is quite unique in that this is a biochemical diagnosis rather than a clinical diagnosis. So we diagnose subclinical hypothyroidism when TSH is high and free T4 or T4 is normal. So, but like, how do we test this in the first place? We look for thyroid functions generally because of some reason. So most of the time, subclinical hypothyroidism may be associated with some non-specific signs and symptoms of hypothyroidism like fatigue, cognitive dysfunction or somnolence or mild weight gain, menstrual irregularities. This is most of the time subclinical hypothyroidism is diagnosed when thyroid function tests are ordered for this, and then we don't find overt hypothyroidism, but only subclinical hypothyroidism is there. At the same time, in large population screening studies, subclinical hypothyroidism has been seen in individuals who are asymptomatic. So subclinical hypothyroidism as such does not have a specific association with any specific symptom or sign. At the same time, when we diagnose subclinical hypothyroidism, many of the time, like non-specific symptoms, which are quite common in the general population also, tiredness and all that can be seen with subclinical hypothyroidism. Was this
Okay.
only question? Was there a second part to the question?
Yeah, when should we treat it?
Okay,
Like,
okay,
what
sorry,
are the
sorry.
subgroups
Yeah.
that we want to
Okay.
treat it? Although we'll have a further discussion on that.
The treatment of subclinical hypothyroidism depends on many factors, like the age is important, like you rightly said, the age is important, the level of the TSH is important, and then presence of antibodies, all these are important. So more than 10 TSH more than 10 generally treatment is indicated. This is because like an improvement in outcomes like cardiac failure or cardiovascular mortality, all that has been seen in people with more than 10 TSH. So more than 10 TSH generally merits treatment. In TSH, if the TSH is less than 10, and if it is between 7 to 10, maybe, then generally in younger patients means less than 65 years of age, probably it is better to treat. Whereas older patients, we know that TSH generally increases with age. So in a person who is 80-year-old, a TSH of 8.5 is normal. So in older patients, borderline TSH, like even if it is above 7, between 7 to 10, generally treatment is not advised. And if TSH is less than 7, if it is above the upper limit of normal, at the same time less than 7, probably factors like presence of antibodies. Anti-TPO antibody positive means generally there is a greater chance of progressing to overt hypothyroidism. There is a progressive disease. And presence of goiter, again, it indicates that there is a thyroid disease present. So such factors are more important when there is borderline TSH, like it is above the upper limit of normal, which is usually 4.5, but less than 7. So in such people, the presence of antibodies, presence of goiter, etc., makes a difference. And younger individuals, like people who are young women seeking treatment for infertility. In such patients, we should consider treatment when the TSH is just about 2. We know that the optimum TSH level in the first trimester pregnancy should be less than 2.5. So in a patient trying to conceive with ovulatory dysfunction, in such people, if it is above 2.5, especially if antibodies are present, probably we should consider treatment. So basically, treatment of subclinical hypothyroidism, we should take into account age, the TSH level, and other factors like anti-TPO and goiter, and also symptoms, probably like menstrual irregularities, all that also probably we should take into account.
Wonderfully explained. That's really true that many of the symptoms are attributed to thyroid hypothyroidism, which is subclinical and probably not the cause of general fatigue. Anyway, so let's move on to next question. I will be asking Dr. Saptarshi. Is there any role of any, now it's like all over social media, you'll find a lot of things like thyroid specific diet. And what is the current opinion on excess consumption of cruciferous vegetables in individual with thyroid disorder? And if you would like to comment on the role of Brazil nuts.
Yeah, thank you, Dr. Sara. Thank you, ITS, for extending this invitation to me. I think what you just asked, I think it's the net is all full of it, and many of our patients will come and they will tell, I have this list of 10 foods or 30 foods, so this will improve my thyroid function and this will worsen my thyroid function. So what do we need to do about it? So again, so if you are talking in the context of subclinical hypothyroidism, so that we all know it's actually in most of the cases it's an autoimmune disorder. There were some African tribes which actually had lots of cruciferous vegetables as their staple food. So the concept of goitrogens and presence of thiocyanates and isothiocyanates and their negative effect on thyroid came from tribes who were having a lot of cruciferous vegetables in excess amounts. So in the current context, the amount of cruciferous vegetables which is there in Indian diet or maybe in South Asian context, it hardly matters that if you're having an occasional cabbage or cauliflower or broccoli, so that amount is not going to damage your thyroid. In the setting of subclinical hypothyroidism, we know the mechanism is different. And the cruciferous vegetables which actually also act, so it's a combination of iodine deficiency, combination of selenium deficiency, combination of goitrogens, maybe some extent to protein deficiency also, that they all act together. So from my side, I don't think that diet or cruciferous vegetables, they have multiple other benefits. They are green vegetables, they have antioxidant properties, they have other minerals also, so they are normal healthy foods. So in Indian context, unless somebody is actually binging on them, it's not going to cause any problem. On the other hand, there is another food material which is soybean. So soya products also have been thought to have some goitrogenic properties. But again, the amount of soybean we are consuming, it's not going to actually matter. So for what I explain to all my patients is that you need to just have a normal healthy diet. There is no diet which is going to cure your thyroid, or unless you are doing something extraordinary, it's also not going to affect your thyroid. But maybe somebody is on a thyroxine tablet. Soybean can actually interfere with the enterohepatic circulation of thyroxine. So the thyroxine medication requirement can increase in if you are taking again a lot of soya products, maybe soya oil on a regular basis, or soya based protein powders, or soya atta. So in those cases, it is not going to actually damage thyroid, but maybe the dose of thyroxine might go up. So for me, diet, you just need to have a healthy normal diet. Goitrogens in Indian context or South Asian context, it's not going to matter.
Yeah, actually, well said. That's what we have been telling all the patients, and it's important to reiterate the same. Thank you so much. I would like to ask my next question to Dr. Sujoy Ghosh. What is the difference between using iodized salt and lot of like non-iodized salt available in the market? Again, wanted to highlight what are the possible adverse effects of using non-iodized salt in the context of thyroid disorders.
Thank you, Dr. Sarah, for that question. Just a couple of comments. I think Mini Ma'am explained very well about subclinical hypothyroidism, something that we actually probably as endocrinologists stop more people from getting treatment than starting people from getting treatment. Just 2 points. Number one, if, for example, the situation, somebody is contemplating to get pregnant or is pregnant, then we should treat subclinical hypothyroidism. That's one area. And the other is, if you have someone with a background where you've given radioiodine therapy and you've got a subclinical hypothyroidism, you know probably that's going to progress toward hypothyroidism. These would probably be two other indications where I would be treating someone for hypothyroidism. Now, the question that you've asked about iodized and non-iodized salt, under the current government laws of my country, it is illegal to sell non-iodized salt. Though we all understand in a country as big as India, a lot of things happen. And, let's not get into the nitty gritties. But the fact is that you should not be selling non iodized salt. Now, there is another form of salt that is often sold and is marketed in a very beautiful manner, is about rock salt, sandak namak, what we call. And some of it, there's various varieties, the pink salt, and you will find it on television, people coming up and saying that's the healthy salt and things like that. Now, most of those commercial ones, for it to be legal, it's also iodized. Normally, the difference is, the common table salt that you and I eat is made from salt water in the marshes, predominantly in places like Gujarat, by evaporation method and sublimation method, to which iodine is added so that at least 15 to 30 ppm is the concentration. Now, the so-called sandak namak or rock salt has a lot of other minerals, including iron, copper, zinc, magnesium, and is touted to be much better than the common iodized salt that you and I take. First of all, let's bust this myth. They are much more expensive, and you will find that there is an expiry date which says, it was created 10,000 years ago, but it has an expiry date 6 months down the line. So let's not get fooled by such marketing gimmicks, because we know if we do not consume some form of iodized salt or some kind of food which is fortified by iodine in other countries, you will end up with iodine deficiency. Now, if somebody does have iodine deficiency, that can manifest in various ways. If you're looking at population at large, we've had several studies in the past prior to the iodination program in India, and that we got an rough idea of what the iodine deficiency status was from the degree of goiter presentation in school children. So that data is already available. So you will have diffuse or nodular goiter if somebody is iodine deficient. Individuals are more likely to have hyperthyroidism because sustained iodine deficiency leads to nodularity and hyperfunctioning of the thyroid gland with autonomy. So that is more common. severe iodine deficiency will lead to hypothyroidism. Severe iodine deficiency during pregnancy can cause major problem in terms of fetal outcomes, and you can even have cretinism, whether it's neurogenic cretin or myxedemous cretin. Neonatal and infant mortality goes up. Neurological disorders can happen. So you can have a whole lot of problems if an individual is iodine deficient.
So well explained, and I would just like to add here. It just makes me think that somehow we are in terms of social media, anything which is trying to say different that gets more attention, like anti-vaxxers. Now we have, and going back to the same thing, explaining. So some that kind of thing that. Something different will get more views and shares. So it's really important to know it's illegal and it should not be at all. I mean, there are no health benefits and it can actually cause harm.
And just
So
one
just
more point, Beatrice mentioned it. There's a position statement that Indian Thyroid Society has come out with in terms of universal iodination, which the readers and the listeners can actually go through and read.
Yeah, that's really wonderful. So my next question would be to Dr. Saptarshi. I wanted to ask him to effectively detect and manage thyroid dysfunction during pregnancy. What's the approach, trimester-specific reference range, and treatment targets, also frequency of monitoring?
So again, we need to understand. So if you're looking about subclinical hypothyroidism, and Dr. Sujay and Dr. Mini both reconfirm that this is one area where you will actually be treating subclinical hypothyroidism in more cases than not. So in most other situations, it will be you won't be treating it, and most probably will be preventing more. What Dr. Sujay said, that from starting unnecessarily getting started on thyroxine. So ideally, you should have a population specific data. If you don't have a population specific data, then the TSH which is acceptable is 0.5 to 4. But again, there is a gray area. So if the TSH is between say 2.5 to 4, that is like slightly elevated in the context of TSH. So because of pregnancy changes, the TSH actually tends to go down. So most probably we need to get a TPO antibody done at that point of time to determine whether there's a need for treatment or not. So TSH is 0.5 to 4 is usually the normal range for pregnancy, maybe 0.5 to 2.5, unless you have a population specific data. 2.5 to 4, get a TPO antibody and base your treatment on the results of TSH as well as TPO antibody. So again, how frequently you need to treat if somebody is having not having hypothyroidism. So there is no such strong recommendation that you have to treat, you have to get it checked every trimester. If the TSH is between 2.5 to 4 and if you have not started treatment, there are recommendations by ATA that you need to do at least once in every trimester just to make sure that the TSH is not going up. If you are actually starting treatment, or then for first time, so till the dose gets stabilized, so the target TSH will be between 0.5 to 2.5. So till you reach a stable value, you need to recheck every 4 weeks. Once you know, okay, this is the dose where euthyroidism is getting maintained, the target TSH is between 0.5 to 2.5. Still, you need to check frequently, at maybe every 6 weeks, but you require some amount of monitoring throughout pregnancy because the dose of thyroxine is going to fluctuate if somebody is on thyroxine supplementation. So again, depends on what the TSH values are and whether the person is getting treated or not.
Yeah, wonderfully summed up. I think Dr. Shashank has not joined the conversation. Some of the questions I will be handing
Can I
over
just
to
make
our.
one comment? Can I just make one comment?
Yes, yes, please.
So the Indian Thyroid Society has actually got a guideline on pregnancy and thyroid disorders, which exactly talks about what Dr. Saptarshi talked about. And it also quotes India's normative data from various centers and talks about that if you have nothing, first trimester is 4, or whatever your upper cutoff is, 0.5 less than that. And the second and the third is 0.5 more than that.
Yeah, wonderful, and we should have for all the residents more resources to read, especially our local guidelines, because uh, as we know, all the diseases are population specific, and as AT has also reiterated time and again that we should be looking at our population specific reference ranges. The well said. My next question is for Dr. Mini Pillai. That now, because I think a very large percentage of our clinic visits are for weight gain, and there has been many trials have shown actually no real benefit in subclinic treatment of subclinical hypothyroidism in weight gain. So what should be the approach, and how we convince the patient that it's not how do we approach, and what's your suggested input on this?
Thank you. That's a very valid, very important question. I would say the increased TSH is probably the effect of obesity rather than the cause of obesity. So that is what we usually tell our patients also. There is this link between obesity, leptin, and TSH. So leptin increases TSH. Probably that is the reason for mildly elevated TSH, which we very commonly see in patients with obesity. So probably this mildly impaired TSH should be disregarded, like especially in children. And I think the obesity or adiposity based, again, it is very important to emphasize that this is a chronic problem. Obesity, it is a chronic health problem. It is not a short-term problem. So we have to educate these people like we educate any other patient with ABCD, adiposity-based chronic disease, and treat accordingly, like the lifestyle measures, drugs if needed, treating other comorbidities, whatever they have. So I think, and also explain to them that this borderline high TSH is probably not the cause, but rather it is the effect of the obesity.
Well said, but it's really a difficult task sometimes convincing patients. But yeah, that's well said. So it's not the cause but the effect. So this is we need to try to tell them the correct thing, not what they want to hear. Unfortunately, sometimes people want to hear like whatever they are being tuned. They want to blame something, so it happens that that's not the reason.
I guess
So
there
we
is
need
no
to
harm in giving a short therapeutic trial. I guess there is of course, the other criteria that we talked about, the presence of goiter, the age factor, the anti-tip, all that apply. Like it is like any other patient with subclinical hypothyroidism. But like if it is, if the thyroid hormone replacement won't do any harm, like suppose this is not a very elderly patient, or like most of our ABCD patients will be relatively younger. So I suppose, I guess, and like what we do in our practice also, explain to them that it is unlikely to be the cause of your weight, but there is no harm in, so giving a short therapeutic trial may help the patient, help convince the patient that TSH is not the cause of their troubles.
I completely agree. And actually, we have to individualize as per the patients. First, like it's not causing any harm, and we can give a treatment trial. Moreover, just have to explain that they should not have the unrealistic expectations that this is the answer to all the problems, and it will help reduce like any significant weight loss. Okay, so I move on to my next question. Actually, I wanted to ask Dr. Sujoy Ghosh, what is the role of selenium supplementation in autoimmune thyroid disorders, and can it? There are actually several trials, however, there has not been any like the results have been variable. So is there any role of selenium supplementation in patients who are subclinical, and can it prevent progression to overt hypothyroidism? Also selenium, like Brazil nuts are a rich source. So there have been a lot of buzz about that. So would like to hear your thoughts on this.
Right. Thanks for that question. The trials have been pretty dodgy and with variable results. Now, if you look at meta-analysis in terms of progression from subclinical to overt hypothyroidism, it does not do so. It does not prevent progression. The only place that probably selenium supplementation has role in thyroid disorders is mild tau, thyroid-associated orbitopathy. There might be some benefit of addition of selenium. Rest, there is no role. That's as of now. There have been studies which have been suggestive, but they are not good studies. And the meta-analysis of whatever we have as of now, we should not be recommending selenium supplementation with the hope that the progression is going to be delayed.
Okay, yeah. Well said. As of now, actually, it's recommended for the tau in the ETA guidelines as well. So,
Only
of
mild tau.
course,
Only
yeah.
mild tau.
So that's of course, but in other disorders, it's like still we don't know. Like, okay, we need some more studies. Okay, so the next question I want to ask again, Dr. Mini Pillai. I started with subclinical hypo. Now I want to ask on subclinical hyperthyroidism, because we know its definitive association with the osteoporosis. So should we treating those at risk factors of osteoporosis, or should we treating all patients with subclinical hyperthyroidism with suppressed TSH, and how should we approach such patients? So I would like to know your thoughts on this.
Subclinical hyperthyroidism, in general, the recommendation is it is sort of the opposite of subclinical hypothyroidism, whereas subclinical hypothyroidism, we will be avoiding the elderly as far as treatment is concerned. In subclinical hyperthyroidism, treatment will be more aggressive for the elderly, because there is risk for osteoporosis or cardiac issues are more in the elderly. So subclinical hyperthyroidism, especially if the TSH is persistently less than 0.1 and more than 65 years of age, it will be better to treat.
Okay, thank you so much. I would like to summarize what an interesting discussion, and then any points if I miss can be added by my esteemed panelists. So as Dr. Mini Pillai told, that subclinical hypothyroidism, we need to treat only in subgroups, certain subgroup of patients, and not in all. Pregnancy is one subgroup where definitely requires treatment. And then regarding thyroid diet, unfortunately, there is no specific thyroid diet, and even excess consumption of cruciferous vegetables in individuals, it doesn't affect. Regarding the iodized salt and the rock salt, as Dr. Sujoy said, it's actually illegal to sell, and we came a long way from disorders which like cretinism and several severe disorders. We came a long way, and now we are unfortunately going back to those because of the people shunning the iodized salt. Then coming to how to approach the thyroid dysfunction in pregnancy, if the population specific reference ranges are available, will follow that. Otherwise, TSH4 can be used as a cutoff, and when treat initially, we need to follow up them more closely. Then can monitor with each trimester. Regarding selenium supplementation also, there is no clear role. It's especially its role is there in mild tau, but in other cases it's not clear as of yet. And subclinical hyperthyroidism we should treat because of osteoporosis risk factors, and especially in the elderly, which is opposite of subclinical hypothyroidism. Any points I would like to add? A final point to summarize from, I would like to hear from Dr. Mini Pillai and Dr. Sujoy. like summarize and just your final thoughts of this session.
I'd just like to clarify that tau is thyroid-associated ophthalmopathy, because I think the short form everyone may not recognize. And selenium, actually, there has been no benefit, like no benefit has been shown in preventing progression of subclinical hypothyroidism to overt also. So that way also, except for thyroid-associated ophthalmopathy, there has been no evidence. Nothing more to add.
I would just like to check with Dr. Sujoy if he wants to summarize his thoughts or he want to add to what I just spoke, and if he's there, Dr. Sujoy.
No, he has, I think, locked out. He had another meeting also.
Dr. Saptarshi is
Okay. I think Dr. Saptarshi, if he's also has another meeting, so I'm not sure if he's there. Okay, so if Dr. So anyone would like to add to this, otherwise we can move on to the next topic. Dr. Pramila, would you like to add to this?
I think
or
we'll
just
move
we
on
can-
to you have excellently summarized the whole thing about subclinical. And as we clearly discussed that only the patients who are planning for pregnancy, for infertility, that's the major indication. And now there are some studies coming up with cognition and subclinical hypothyroidism where people have seen mild deficits in verbal memory, and in detailed mental examination, they have found some deficits in verbal memory and some of the other areas of the memory. So there are some studies which are coming up, and some people have seen that in younger population, there may be some benefit of treating that population group, because that might benefit, especially the people who are doing work like executive functions and all, where they need very specific the things in the memory, and if little bit is disturbed, that can cause problems. So those are the other areas, and also some of the psychiatric disorders like depression and all, where there may be some indications of treating subclinical. So those are the other areas where a lot of research is happening, and there are some benefits which have been shown in some of these areas, but only the younger population, not definitely the older population. All the studies have shown benefit below 60 or 65, not above 65 for sure. So the other things I think we already discussed, and as we discussed, the selenium has a role in just mild tau, but not in all the other indications. Those studies are not very contributory at the moment, so we don't have clear-cut evidence in the other domains of hypothyroidism or hyperthyroidism with selenium. So I think you have nicely summarized the whole discussion, and these were the extra points which I just wanted to add. Yeah.
Thank you.
Thank you so much. Thank you.
Thank you, Dr. Sara, Dr. Mini Ma'am, Dr. Sujay Ghosh sir, and Dr. Saptarshi sir for clearing most of our doubts on one of the most debatable topics. So indeed, it was a very exciting panel discussion. So moving on, we have the session on congenital hypothyroidism, which is one of the most commonest cause of preventable mental retardation. So there are differences in the screening methods, the diagnostic modalities, and treatment protocols as well. So, to chair this burning topic, we have Dr. Rajesh Ratput sir, who is the director of the Department of Endocrinology at Medanta, Gurugram. And I request sir to introduce our second international faculty, Dr. Deena Shrestha madam. Over to sir.
Thank you, Dr. Ganvi. Good evening, friends. Well, I think aptly said that congenital hypothyroidism is one of the most controversial topics. But rather than I'm saying controversial, what appears to me is one of the most neglected aspects of the thyroid disorders. In India and probably in Southeast Asia, and Deena will tell us about the situation in Nepal, probably not every child which is born is screened for thyroid function by thyroid function. And we know this is one of the most preventable cause of mental retardation. Despite this knowledge, still I know that there are limitations because of so many reasons which we can discuss later on, but every child is not screened, which result in we are underdiagnosing this problem, and when we are even diagnosing this problem, probably diagnosed at a late stage and not treated appropriately. If we see the treatment protocols also, apart from screening strategy, where there is controversy T4 based or TSH based, which I think Deena is going to discuss, and then treatment strategies, because when we look at the microgram per kg body weight dosage of levothyroxine, it is quite different from congenital hypothyroidism as we see it for adults. So there are many issues, and for this important topic, the speaker is none other than our good friend Dr. Deena Shrestha. She is from Kathmandu, Nepal. She is working there as a senior consultant endocrinologist, Norvik International Hospital. She is also working at Siddhi Polyclinic, Kathmandu. She is DM Endocrinology. She is president of SOF, South Asian Obesity Forum, immediate past president, Dean, Diabetes and Endocrine Association of Nepal, and past president of CEPHIS and executive member of PCOS Society in Nepal. So these are few of the things about Deena. Apart from that, she's a wonderful person. So I, without wasting much of that time, I invite Deena to present his deliberation. Over to you, Deena.
Thank you so much, Dr. Rajput. I mean, after all that, I'm like, is that really me? So thank you for all your love and honor, and thank you, ITS, for extending your thing. So like you said, I think for an adult endocrinologist, I mean, all the talks before me have been wonderful, right? Like everything is updated, everything is so good. And subclinical has been so controversial: when to treat, when not to treat, how to treat, whom to treat, all these things. And everything was so well done. So then it's like congenital hypothyroidism. It's I think it's just something that is, like you rightly put, just neglected. We're not thinking about it a lot. I mean, as endocrinologists, as adult endocrinologists, we are aware of it, and we do try to, at least make sure that the babies born to our thyroid mothers or in our hospitals from our patients at least screened. But definitely the mass message is not there. So my today, I'm just going to share my screen here. So today this is more not about more like updates like Dr. Beatrice and the last session that we had, which was excellent, but just going back on the theory and some papers, and just reviewing our what we already know, and then just to put it out there that we have to work on this, because definitely congenital hypothyroidism is important and preventable cause of mental retardation. That is the most important thing, right? And the clinical manifestations of this can be subtle or absent at birth. Like some of them are really dramatic, but some of them just can be very, very subtle. And of course, we know that when we talk about it, it is important because it impacts our brain development, the myelination, the neuronal connections, all of it is impacted. And many of these newborns that are undiagnosed may suffer later from mental retardation. So like we're saying, like, is it neglected because it's not there, it's very rare, or is it just because we kind of are not aware of it? So the incidence globally, you can see, is from 1:2000 to 1:4000. So it's not very, very rare. And in South Asia, it's 1 in 1200, right? And if you see right below, we can see that from the ICMR that actually it's 1 in 1130. So actually India has a higher rate for newborns. Sorry that I don't have for Nepal, but definitely if you see in China or Vietnamese, Hispanics, I mean, it's there. And if you see that, okay.
Ma'am, you can, if there is a PPT that you want to share, you can share that, ma'am.
I thought I was sharing. That's what I was thinking.
Yeah, just click on that button, ma'am, the share button. Try redoing once again, ma'am.
Okay, I really thought I was sharing it. Now it's going on. Sorry.
Yeah, just open your presentation, ma'am.
Wow, I can't believe I was just speaking all that without the thing. Now can you see me? See the...
Yeah, we can see that, ma'am. Cool, ma'am. You can go ahead, ma'am, please.
Okay. So
it's okay, ma'am. Just continue, ma'am.
Yeah. Where I was, yeah. So as you can see here that actually India is not very rare. Actually, globally, we can see that India actually has 1 in 1130, which is actually more common than, the Hispanics or the non-Hispanics. So how do we classify the congenital hypothyroidism, right? So CH can be permanent, transient, and syndromic, depending on whether they need a treatment for life, whether it's just temporary, depending on whether they'll recover or not, and whether it's syndromic, like part of other organ system failures. And also we can see that the etiology can be different. Like we can have a CH, but it is because of different etiologies. So the most common form is thyroid dysgenesis. That can be aplasia, hypoplasia, and ectopic gland, which is in 66%. So a lot of actually these glands are ectopic rather than aplasic or hypoplasia. And then there's also cause of thyroid dysgenesis is unknown. So there can be mutations, inborn errors of T4 synthesis, secretion, and utilization, 2/3 of heritable causes. And then, of course, the transient hypothyroidism we know can be because of the maternal autoimmune thyroiditis and the medications that these mothers take for Graves' disease. Dr. Sujay has talked about iodine and the importance of it, and we can also get endemic cretinism because of iodine deficiency. These are the few genetic mutations that are there. So you can see that actually, if you see the NTN, I'm not very good with these things, but you can see that there are certain genetic mutations that have been identified that can cause thyroid ectopic, or the TUBB, which can cause thyroid dysgenesis, TBX, which can cause hypoplasia in the parathyroid, but the thyroid is in situ, and TPO, which is the thyroid hypoplasia, which is rare. Right. So, I mean, what we're trying to say is there are different causes, and if you want, you can actually look for them. So, what are these? How do these children present to us? Right. So, like we said, we cannot solely wait or think that they're going to be symptomatic. There are going to be a lot of these patients who are not going to be symptomatic. But if they are, we can see that they are what we call good babies, right? No cry, excessive sleep. We think that these are good babies. I'm always telling my patients, no, that's not the good thing. If they're good babies, then they can be our hypothyroid babies. Decreased activity, poor feeding, weight gain, hoarse cry, poor growth, and constipation. Sometimes, of course, we want to go even in the family history, whether they had infants with similar affliction, unexplained mental retardation, and prenatal birth, and the maternal history of thyroid disorders. Signs: large anterior fontanelle, jaundice, hypotonia, cross-facial features, mottled, cool, and dry skin, umbilical hernia, myxedema, pallor, developmental delay, prenatal birth, and any child which is less than 2,000 or more than 4,500, and more common in multiple growths. So this is something that we want to learn about or think about, is also thyrovigilance, the action or state of staying alert to signs and symptoms of thyroid disease, right? So I think we do know that in adults and children, both of them, that sometimes they're not very symptomatic, they're just vague symptoms, and we just have to have a lot of this like thyrovigilance, where we have high level of clinical suspicion, and that is when we get them, and then we investigate them thoroughly. Working in a corporate hospital, I know that investigating thoroughly sometimes is not as easy. Patients usually blame you for just trying to make some extra money, but we as doctors, when we believe in ourselves, we have to tell them, we have to explain. I feel that telling them, talking to them, and giving them knowledge will make them more aware and build trust and give them more reason why that we are further investigating them. Okay, so presentation, like I already said, right? So there can be macroglossia, enlarged fontanelles at the time of thing, and anemia can also be there. So, okay, so the whole point is that, okay, we know that it is there. It is not very uncommon. The presentation is not very, in some of them, it's the signs and symptoms are there, but a lot of times it can be subtle and absent. So what is it that we are really worried about? It is obviously that there's a good relationship between the IQs and severity of CH, right? So the relationship between the IQ and the serum T4 at diagnosis is discontinuous, but below a certain threshold of 3.3, actually we can see that there's a 10-point IQ deficit. A lot of times, I do tell my patients that, when we're giving enough thyroxine, or, we are checking the patients. So I do tell them that we owe it to the society that we have kids that are intelligent, the IQ is good, we're not missing all this. So, and then they smile and they're like, yeah, okay, so that's also a way of telling them that, it matters. And above this threshold, which is of 3.3, children are unlikely to suffer from a 5-point deficit. Okay, so this is something that we can also see, that the skeletal development at the time of diagnosis, that is less than 36 weeks of gestation, or an area of knee epiphysis. So if they can measure that, can have a significant lower IQ. So this is the same thing, but this is 1972. Actually, I was glad that this paper was there, that years and years, decades and decades ago, before AI and before so many randomized trials and, all these things, people knew that you have to treat them early. So influence of timing, right? So if you treat them earlier, which is less than 2 weeks, or late, actually, that also matters. And if you give them a higher dose of levothyroxine and compared to a lower, also makes a difference. So these are charts just to show that untreated CH patients, unfortunately, they have severe mental retardation. And if you actually treat them early and adequately, that they can have a really good IQ, right? So we need vigilance. Vigilance, the action of state of keeping careful watch for possible dangers and difficulties. So I just wanted to put these things that, there's this. Then the other point is, okay, we know that it is important. We know that we have to treat them early, right? So the thing is that, okay, so how are we testing? What are the numbers that we are looking for? When do we test? Like as Dr. Rajput was saying, like, do we test them on time? Are we testing every kid? Do we know the numbers? As we saw in subclinical, in pregnancy, it's 2.5 to 4, right? And then if it is an adult, it's 10. But what about in children, in neonates, in premature? Are the TSH the same? And the answer is, of course, no. So we should know that the physiological changes that occur in a term neonate is like by cold exposure, the TRH and the TSH surge occurs within the first 30 minutes after birth, right? And then the serum concentration actually goes really high, 60 to 80 typically, right? And then it starts decreasing, and about in 24 hours after delivery, it's about 20 MI. Then it's slowly over a week, it will go down up to 10. So sometimes this is important as adult endocrinologists, because we are so used to, I think that 10 or 4, and we do have pediatric endocrinologists, but we know that children born to our mothers will come and show us those reports. And so we have to be aware that no, actually, there is actually a nice wave that comes for these children. So the screening has to be done correctly. So what we need to do is, I particularly write 72 hours, but that's up to you. So we know that the TSH surge starts in 30 minutes and may persist up to 48 to 72 hours. So we want to check it around after 72 hours so that we don't make the patients panic, But the good thing is the cord blood is actually largely spared. So nowadays in my hospital, we do the cord blood test. And it's better than pricking, and, the patients also, they don't mind. So we do tell them and we do the cord. So either we do the cord blood or you can do a postnatal day 3 to 5. So usually we tell them at discharge, you check your baby's thyroid TFT. So this is a paper by Ravi Bhatia and Dinesh Rajwania from the department in Udaipur, Rajasthan. I don't know if Dr. Rajput knows these people, but so they said that, yeah, you can do the umbilical blood cord, and 20 is a good cutoff for screening, and 30 can also be used for logistic angles. So what we are sure about is that for the TSH 20 is recommended as a cutoff for cord blood and postnatal screening samples after 48 hours of age. Anything that's more than 40 is recommended for defining positive. So if you get a 40, you need to act immediately. It's not like, oh, okay, this might be this, or let's go for this, or let's wait. No. Whereas those that are between 20 to 40, if you want, you can wait for a few more days, like a week or 10 days, not like months, obviously. And so we have this nice algorithm for screening and detection of congenital hypothyroidism from the Indian Journal of Pediatrics, which was published in 2018. So you either do a heel prick. Heel prick seems easy, right? But nobody is doing it for some reason. Like we do cord blood or we do a venous sampling. In our hospital also, we are not doing heel prick. Later we can ask what is the trend in India. But for us, it's either of these. I'm going to put myself here. And so you can see that they put that if the TSH is more than 20 or if the TSH is more than 80 and 40, then you have to start definitely doing a venous sample, right? After 72 hours. And then if it's elevated, then you start treatment with a low T4, but if the normal T4 and a high TSH, then you repeat TSH after 2 weeks, and if the TSH is below 10, then you're fine. But if on the screening your TSH is initially less than 20, then obviously you're normal, but between 20 and 40, then you can repeat the TSH in like less than 2 weeks. If it is more than 10, then you can wait for more than 2 weeks. But if it is more than 20, you have to do it before that, right? And then depending on what the results come, you decide whether they are normal. And if you want, you can start the treatment, but also that sometimes it is a good idea to go for etiological diagnosis. So you want to go for more further tests and imaging, which I'll show you later. Okay. So the laboratory test, of course, in my country, usually when we say a TFT, it comes with the T3, FT3, FT4, and the TSH, not only just T4, but I know that in some countries you can do T4 and TSH. We can do the antibodies. We can also do the TBG tests. Okay. So what are the imaging studies that we can do? Actually, we can do the thyroid scanning in these children. It is useful for defining the cause, may aid in genetic counseling, and it aids in distinguishing from the transient to the permanent one, right? And the presence of an ectopic gland. And also, but it is not required to confirm the diagnosis, but the etiology of it. So what we want to say is, like, if you think it is the TSH more than 40, you want to start treatment if you can't get a scan. It is not that, oh, first let's get a scan and then do it, like we do some in hypothyroidism or Graves in Nepal, at least in our clinic, we wait for that. But in these children, no, you're not waiting for that. If the TSH is more than 40, you're treating them. If you don't have a technetium scan, it is not possible for financial or other reasons, you can go for an ultrasound. But the only thing is, in the ultrasound, what you can do is you can miss the ectopic glands, right? And of course, like, the one I showed before, that we can see for an ossification at 36 weeks. And that also shows that whether they have these effects of hypothyroidism. So this is a good, this is last of these busy tables. But so see, you can do the ultrasound of the thyroid gland. And if the gland is absent or small, not visualized, then you know that, it doesn't have it. But if it is absent in an ultrasound, you might want to go for a technetium scan. If it is small gland, you know that it is hypoplasia. If it is an enlarged gland, then it can be endemic iodine deficiency, reduced uptake in the thyroid, can be maternal antithyroid drugs. It can be some mutations. It can be dyshomogenesis. And then if the size is normal, it can be also because of the endemic iodine deficiency. It can be because of TB2 associated CH. And this depends on the uptake, whether the uptake is there, salivary. So it can again be another gene mutation. Or the reduced uptake from the scan can be because of the perinatal exposure to excessive iodine and so forth. So what we want is that we want to be vigilant, we want to be thyrovigilant, and we also want to be pragmatic. So we want to be proactive in screening and managing of thyroid disease, right? Okay. So okay, now we know that it's important. We know how to screen. We know if we do find the problem, we want to treat it, find the etiology, what happened, because we want to know whether it's transient, whether it's permanent. And then once we know all that, we want to start treating them, right? So the initial dose of levothyroxine is actually high. So for us, adults, is 1.7, but for a young neonate, it is 10 to 15 micrograms per kilograms, given as a single dose as crushed tablet expressed in breast milk. So I think that we don't have to put them empty stomach. I think that's what it wants to say. You can just put it in the milk and just give it to the baby. The serum T4 is measured every 2 weeks, not 3 weeks like us. Ours is at least 3 weeks, but we can do the T4 every 2 weeks, and then TSH every month, and then we can follow it up every 2 months till the baby is of 6 months of age, right? And we titrate accordingly. Every 3 months during age 6 months to 3 years, and then you can just, as they become more stable, more euthyroid, you can try to do it every 3 to 6 months thereafter, and then till completion of growth and puberty. Babies who are the possibility of a transient CH could be re-evaluated at the age of 3 years, and for permanence of CH and the need of the lifelong therapy. Hearing test and clinical evaluation for other congenital malformation are to be performed for all babies with CH, just in case they have other mutations or other syndromic or something like that. So doses, like I said, this is more like a table form so that it's easier, more visually appealing. So it's like 10 to 15, then you go down to 8 to 10. In about 6 months, you can see. But also it depends on what your TSH levels are, right? And what your targets are. And then about 6 to 12 years, 4 to 5. So it will keep the microgram per kilogram per day will come down until, of course, they reach growth and puberty and then reach ours, which is 1.7. This slide I just put in because I thought that what we want to do is that there is studies that say that a small difference in the T4 dose actually has a large impact of IQ. So we should not be, we should not have inertia to increase the dose or give the patient the T4 doses which it needs, because even a small dose can actually have an impact on the thyroid, on the IQ. So to conclude it all, congenital hypothyroidism is one of the most common preventable causes, which we said even in the beginning, and that is the most important thing to take home today. We have to screen them. The best way to detect infants is by screening them. The large population of newborns, we have to screen everybody, and we really should. And once the diagnosis is made, we should not dilly-dally. Treatment should be started within a few hours, within days, few weeks, whenever we think it's necessary, and because it is needed for the neurodevelopment outcomes. And and if we saw that if you actually treat them well, they actually do very, very well. And the etiology of the most common cause is dysgenesis and is largely unknown to the increased incidence of CH. So thank you very much. I hope.
Thank you, Dina. Well, for nicely covering the topic of congenital hypothyroidism. I think you have not touched upon whether T4 strategy is better or TSH strategy is better, but I now believe largely if we are screening, you can stop sharing the slides.
Okay.
So if we largely feel that if facilities are there and if we are screening our newborns, then probably both T4 and TSH should be measured, because it will make more simple for the general practitioners, pediatricians who are not trained in endocrinology, rather than going into the gimmicks that what is a recall rate, which is missed on T4 screening, what is missed on TSH screening. So those things then need not to be remembered, which are more complicated little bit. So for general practitioners, pediatricians, this is a message. If you are screening, screen both for T4 and TSH. But then one has to remember two important messages, and this is our old teaching in old days. Whenever you have TSH more than 40, start treating it. Do not wait. You can again confirm it. That is not an issue. But more than 40, treat. Less than 20, do not treat. Wait and watch. You can repeat. 20 to 40 is a gray zone. I know, and then all these algorithms comes into picture. Another very important message is that therapy, even in India, is not available in medical college, small private, not free. And again, that ultrasound, at least starting the treatment, do an ultrasound. If you find a large gland, also gives a clue to large number of things in pediatrics. Only in select cases, technetium, we needed facilities are there, do it. But if for some reason you are not able to screen for etiology, then please do not wait. Start treatment immediately. Early treatment is the critical. Brain development is complete, and then you can withdraw the treatment. You can find out the etiology if it is needed, or if you suspect transient. So these are some of the very important points which one must remember as a lesson when you are seeing such childs, and it is not uncommon. People are bringing their small child, say, at age of 1 month or 2 months, and they are carrying 2-3 different reports. They're confused what to do, what not to do. So these are some of the important messages. I do not
I think
see
I
any
agree
question in
that
the
I
chat.
think what we have to understand is that just we first need to screen and treat adequately. Like those are the two things that we should,
Yes,
yeah.
yes. We have to screen, and probably, if possible, every newborn should be screened. And then, if needed, treatment should be initiated. Rest of the things can be done at any point of time. If there are some comments from Dr. Ganvi and Dr. Pramila who are also with us, you are most welcome to add your views on congenital hypothyroidism.
I think there's a problem with the network.
Yeah, there are no questions from the audience. So I think questions are not there from the audience. For the benefit of the audience, I think some of the people were asking that how late, till what time we can wait, like 1 week, 2 weeks, 3 weeks. So they just wanted to know that, like, in case we have to start treatment and if we have a doubt about the report, like it's less than 20, till what time we can wait, how late we can start. That
Deena?
is also necessary. Dr. Deena, can you touch upon that? Because some of the people are asking that question,
Yeah.
that how late we can start, if at all we are
Less
waiting
than
for a
20,
more.
I think that algorithm is that
I think one should not wait for more than 2 weeks.
Yes.
2 weeks is a critical time. If you have any confusion, start treatment. After 2 weeks, any TSH which is more than 10 is actually abnormal.
Yeah.
So you should not wait beyond 2 weeks to start treatment for congenital hypothyroidism. This is again very clear.
And then we can reevaluate at the age of 3 years and then take a decision. And anyways, in such cases, what we do is we follow up these patients. So we'll know if the TSH is going very low or something, and we can always reduce the dose and take a call. But we should not wait beyond that, because then it will cause irreversible brain issues and then it will not be reversible.
At least not irreversible, but then there is a big mark of decreased IQ, which nobody wants actually for their children to grow with. So there is always an error on the positive side in such type of cases.
Right.
So it is better you start treatment, keep TSH within. Another very important message. Sometimes we see such type of children who has been started on treatment, but their TSH is still not within the normal range. So they are coming with TSH of 6 or 7. Again, please do not chase a TSH in such type of children's. Even 6 or 7, they will develop a normal brain provided T4 is in the middle or high normal range. So you have to target a T4 in the mid normal or mid to high range, and do not chase TSH, because TSH takes some time to come down within the normative data. So it has been, again, large number of studies have proved. So people are referred to us, children, they are coming, TSH 7 children, 7.5 children, what to do? We are worried whether brain development is normal or not. Again, so it's an important message. Please do not chase TSH and do not make child hyperthyroid. If you are unnecessarily keep on increasing the dose, T4 will increase, and hyperthyroidism producing in a child again has detrimental effects. So that also needs to be avoided by careful titrating the dose. Deena, you want to add something?
Yeah.
I mean, definitely that is there. But I was also saying that when it comes to the treatment part, like, there was that one thing that showed that, the bone ossification, the knee one. Like, I think that is an important thing to see, that even if that is already there, then you don't want to wait even those 2 weeks. You want to start treatment immediately. Thank you, Dr. Pramila.
Yeah.
So right. So if there are no more questions, I think it's time to pay our thanks and regards to Deena, who has joined from Kathmandu for today's webinar. Thank you very much, Deena, for nicely covering the topic of congenital hypothyroidism. And I hope we have delivered some good, important practice point and learning messages for all those who are attending today's webinar, and will help them in their routine clinical practice whenever they see such type of patients. And I always say, if you have any confusion, all of us are there around the corner. Please do not hesitate to send such type of children to us, at least for getting an opinion, so that the right thing can be done at right time. Thank you very much, Deena. over to the
One last question has come if you want to take
yeah,
it.
yeah.
Thyroid scan can help in looking for ectopic thyroid gland in case of congenital hypothyroidism. So that's a question from the audience, that can it help in looking for the ectopic thyroid?
I think that is the purpose of the scan. You know what?
Yes.
When on the ultrasound you cannot see it, then
Yes.
you want so I guess that's bullseye. That is what you should be using it for.
Absolutely. And always remember, ectopic thyroid glands are functioning to some extent. So these type of actually children require lesser amount of levothyroxine to make them euthyroid as compared to some of the other causes of congenital hypothyroidism. So if on a simple ultrasound you are not finding a gland and you are suspecting either it is ectopic or it is a thyrosis and your technician scan immediately is not available, do not rush for it. Do not say that you cannot start your treatment. Start your treatment. That is most important point. If there are no questions, then Pramila, over to you.
Yes, thank you. Thank you.
Yes,
Thank you. Thank you, Dr. Deena.
Thank you,
Dr.
madam.
Okay,
Yes.
thank you. Bye. Bye.
Yes. Thank you, madam. Definitely, it was a very engaging and informative deliberation, and Dr. Rajesh Ratput sir for your valuable insights. So, another exciting session awaits us this evening, where the latest advancements in the management of solitary thyroid nodule will be discussed. Here we have Dr. Roma Pradhan, madam, as the moderator. Madam is the Associate Director, Endocrine and Breast Surgery, Medanta Hospital, Lucknow. So, I request madam to invite the esteemed panelists for the session. Over to madam.
Very good evening to all. It's my really proud privilege to have such great panelists on this session. So we have surgeons here, we have pathologists, we have nuclear medicine and endocrinologists in this panel. So first I would like to invite Dr. Amit Agrawal, sir. He's the Director, Endocrine and Breast Surgery at Medanta Hospital, Lucknow. He's my teacher, my mentor, and he has trained more than 70 endocrine and breast surgeons who are like all over India. So he needs no more introduction.
Thank you. Hi, everyone.
Next. Good evening, sir. Next, we have Dr. Arun Menon, who is also Secretary of ITS. He's Senior Consultant Endocrinologist at Aster Jubilee Medical Complex. And we know him well. I hope he is able to join, because I was getting a message from Kanavi that he's not.
He has joined, ma'am. He has joined.
No, he has joined. He is there.
He has joined.
Yeah.
He's here.
So now we have another endocrine surgeon, Dr. Himagarish, who's Professor of Surgery.
Good evening, everyone.
Good evening. Good evening. And next, we have Dr. Shashwat Verma from Nuclear Medicine. He's currently Associate Director at Apollo Medics, Lucknow. He's also my colleague in my previous institute. Then we have Dr. Nidhi Anand, who's a very dear friend of mine, a pathologist from Department of Pathology at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. So I think we should start our...
Dr. Roma, also we have Dr. Shashank Joshi, who's joining this panel. He is our immediate past president. He is a senior consultant from Mumbai, and all of us know him. He is a very senior endocrinologist, one of the very senior, and he is our immediate past president of the Indian Thyroid Society. So sir has also joined. Yeah.
Welcome. Can you please allow me to share my screen?
Go ahead, ma'am. Go ahead, ma'am.
It's visible?
Yes,
Yeah,
ma'am.
it is.
You can go into slide mode, ma'am. Yeah.
Yeah.
Yes, ma'am.
So we have this panel discussion on new insights in evaluation and management of solitary thyroid nodule. So what is actually solitary thyroid nodule? Just a second. So it's a discrete lesion within the thyroid gland that is radiologically distinct from the surrounding parenchyma. We all know that because of the high resolution ultrasound, we get more and more patients of these nodules in our OPD. So, but why we need to worry about this? So there's a worry for patients as well as for the clinicians who are dealing with this. First, we need to exclude the thyroid malignancy. And what is the optimal management, surgical follow-up or non-surgical management? So whenever a patient approaches to us in the OPD, we go along a stepwise approach. So this girl, 19-year-old medical student who presented to us in the OPD with the complaint of anterior neck swelling. So the first question for Professor Amit Agrawal, sir. So how do you approach such a patient who presents to you in the OPD? So what are the history taking points you would like to share with us?
Yeah, so solitary thyroid nodule is one of the most common problems that all thyroidologists see in their OPD. And whenever confronted such a patient, as you rightly mentioned, our most important point is to exclude or confirm sort of malignancy in the thyroid. So history taking does give you some idea, and perhaps the most important would be whether there is some rapid growth in the last couple of months, that would be a pointer towards the nodule being suspicious of malignancy. A family history is also very important. You have a history of either some genetic disorders or even non-genetic, but history of papillary cancers in the family itself is also a pointer. History of exposure to radiation, as you mentioned in your slide, is also very important. Whether the patient has received in childhood some sort of radiation, because that increases the chances of malignancy. So these are sort of clues that raise the red flag, and then you go ahead from here to the next part of examination.
So for examination, I would like to ask Dr. Arun Menon, what are the clinical features that will actually warrant you to refer these patients immediately to a surgeon or the endocrine surgeon, basically?
Roma, I'm not sure whether there's a lot of background noise. Is there quite a bit of background noise?
It's okay, sir. Go ahead, sir. Go ahead, sir.
Oh,
it's okay.
perfect. I'm happy. So I think the important thing when we see these patients are large proportion of these patients don't necessarily have any symptoms. So they are, many a times because of which our history taking becomes very, very basic. So it is very important that we stick to a pattern and get history of what, as Samir sir had said about the thyrotoxicosis or symptoms related to toxicity. But the urgent ones, the ones that need urgent referral, are also have to be sought out. I think we need to ask the patients whether these are there. A recent voice change or something that a hoarseness of voice that has happened. I think many times it's important that we ask that history very clearly. Of course, when there is stridor, that is obvious for us and for a clinician, and obviously for the patient as well. So that becomes very much easier. This is where the clinical examination becomes very important. Again, we have a tendency these days to depend on ultrasound and ultrasound results. But I think a basic inspection and a palpation of a nodule becomes extremely important, because many times when we get that feel, that very firm or hard nodule, straight away you know that this is something which needs to be dealt with straight away. The nodule fixation to adjacent structures, again, not very common. It may not happen all the time, but I'm sure our surgeons here at endocrinology would be seeing a lot of these cases. Compared to what the number of cases that we see, this might be still quite small. But the most often, rather than the papillary, it is when you have an anaplastic or the more rapidly growing ones that you get this kind of fixation to the adjacent structures. So that could be to the strap muscles, it could be even to the recurrent nerve, even up to the larynx, so esophagus. So it can pretty much go into anything. It is not that common. However, unless you have a high index of suspicion, you might miss this. But when you see these sort of nodules, I think it is fairly obvious that you have something going on, and an urgent referral to surgeon is the main point to be done at that time.
So very well said, sir. So especially for our residents, we should not straight away write the investigation. A clinical history and examination is an important part of managing these patients. So next comes the triple assessment of these. So we know that we have been doing blood investigation, TSH, T4, imaging, and cytology. This is a traditional that how we manage these nodules. So Dr. Himgarish, can you just enlighten something like what are the problems with this traditional approach and what is the modern concept of diagnosis of these nodules now?
Yeah, thank you very much, Roma. And thanks to Dr. Pramila and the team for organizing this and having us on this podium. Yeah, there's something called an indeterminate nodule, or an autonomic nodule or something like that, where the risk is sort of in between. We can't say with definitely with certainty whether it is something that is benign or whether we need to worry about it. The other aspect is, of course, this indeterminate. So we need to, investigate further, maybe do an FNAC, maybe do an ultrasound guided FNAC, maybe fall back on the imaging and the various characteristics of a nodule that can be picked up on imaging that are pointers towards, the nodule being ominous. Let's come to that. But one little footnote is that it doesn't have to be malignant for a nodule to be significant. 2% of nodules grow, and even benign nodules can grow big enough in the neck. They can get into the chest. They can, ultimately end up with being a retrosternal goiter, wherein the patient will have a significant difficulty, significant affection of quality of life, which necessitates surgery. Anyway, that's besides the point. Maybe an ultrasound will tell us, the various characteristics of a nodule. Is it a homogeneous nodule at all, or is it heterogeneous? We talk of complex cysts, where a part of the cyst wall is thickened. It is thicker than the rest of it, and that is the point. That is a place where we need to be suspicious that okay, this could harbor something that is more malignant. Or is it hypoechogenic? Is it markedly hypoechogenic compared to the rest of the nodule? Are there microcalcifications? Is there alteration in the architecture? Is there chaotic vascularity? Now, these are certain pointers that will lead us to investigate the nodule more. Of course, there is a scale. There is a Thyroid score where we score all these features on a scale of 0 to 3, and then we have a cumulative score, and then we give a nomenclature of Thyroids 1 to Thyroids 5, and Thyroids 5 being the most suspicious and Thyroids 1 being the most benign. Yeah.
So I think just a point. We as thyroidologists, we should insist from our radiologists that we get a report of thyroids rather than just the ultrasound descriptive report. A thyroid scoring does help us surgeons to take a decision. So I think we should insist to get a thyroids report. In these times, it's mandatory that a thyroids report is obtained.
So this is one of the studies by our president, ITS. So they compare thyroids with Bethesda. So we'll be coming to Bethesda as well right now. Can somebody stress upon the elastography? Is that necessary, or is that standalone can be used?
Yes,
Can I take that, Dr. Roma?
Yeah, go ahead.
Thank you, sir. Yeah, this is another thing where the flexibility or the plasticity of the nodule is being assessed. Generally, a malignant nodule is more rigid than a benign nodule. So when the ultrasound, when the sonologist performs the scan, he puts the probe on top of the thyroid. Then we spot the nodule, and then we try and put pressure on the nodule and see if the nodule is pliable to pressure. See if the nodules, the architecture or structure changes. I mean, is it compressible? Malignant nodules are less so compared to benign nodules, and even there is an elastography score. So the higher the score, the more the chance of being the more propensity of malignancy. So a rigid nodule is looked upon with more suspicion.
So just to add to Agrish, again, I would say I think as thyroidologists, we should insist with our radiologists to do elastography. It just takes 5 minutes more. There's an inbuilt software, but it gives you a lot of information and complements your diagnosis of malignancy in combination with thyroids and Bethesda. So I think in today's time, the modern radiology report should carry both elastography and thyroids.
True, sir. So we are routinely asking our radiologists for this elastography report. So the next question is for Dr. Shashank Joshi. So when do you advise FNAC for these patients that come to us, like based on the ultrasound features? So do you follow the ATA guidelines, or do you have your own guidelines or the things that you follow?
Yeah. So I think before I come to the FNAC, I have a very simplistic approach. When you see a nodule, I agree with Arun that we need to do history taking. He highlighted the red flags, which we do. And then we looked at sonography, and then we are coming to an FNA. A point before that is I always follow, because there are a lot of primary care physicians listening to all of us, a simple 3C approach. If there is a nodule, the first C is cosmetic. If it is large in size and it is cosmetically disfiguring, or if the patient wants a surgical removal, it should be offered. So I think that should not be denied. And we see a spectrum of cases in India. We can see the urban elites to the poorest of poor, but cosmesis does matter. So I think that's number one. Please keep that old slide. I'm going to come back to that. Second C is, of course, if there's any compressive symptom, which Arun highlighted, on the trachea or the esophagus, definitely surgical intervention is mandatory. And third is suspicion of cancer, which is where whom to do FNAC. For example, if it is less than a centimeter with high suspicion, more than a centimeter with intermediate suspicion, 2 centimeter with low suspicion, no FNAC with polycystic. But as I said, all these definitions are very arbitrary, and they're based on a probability model of a negative predictive value and a positive predictive value. And therefore, there will always be anywhere between a 0.5 percentage to a 10 percentage variability, and they are highly operator dependent, cytology dependent. We also know that some malignancies are angioinvasive and have a capsular invasion, which can be missed by an FNA. So you cannot have a very high probability. So I do agree to what has been listed here, that based on the suspicion. So sonographies have the telltale markers like calcifications and some morphometric features, which are now very well published, and there are very good atlases available on the ATA website, which allow us to make a morphological high index of suspicion to know that the likelihood of malignancy is higher. And they're pretty good for papillary thyroid cancer. But when it comes to follicular cancer, we all know the angioinvasiveness, the capsular invasion, and therefore in those situations, necessarily an FNA may miss out a follicular malignancy, and we may need to do a little more deep diving. So that's my take on this, that yes, FNA is important, and even for a purely cystic, sometimes you can be draining it out and the nodule may just fall apart. So it's not that it's totally, FNA is not always diagnostic. Very rarely, occasionally can also be therapeutic. So it's important to recognize that. The key to an FNA is the sonography needs to do multiple sites. Here, we are usually doing a single site because it's a solitary nodule, but the cytologist is the key. And unfortunately, in India, we don't have easy access to molecular markers from the FNA, and which is available in the US. And it's a business by itself, the liquid biopsies and so on and so forth. It's a different subject matter of discussion. But I think I follow a very simple 3C approach, and I do encourage FNA in most people because it's easy, but the cytology holds the key.
Definitely. 3C approach for the residents. It's very important to remember and memorize this. It should be there in your mind always. So once we have advised, the surgeons or the endocrinologists have advised FNAC, the FNAC done, and then comes our endopathologist. So Dr. Nidhi, I would like to welcome you to
Hi.
this.
Hi, thanks, Dr. Roma. When the patient comes to us, cytology, FNA, without guidance or without the ultrasound guidance, this is very simple procedure. This is palpable nodule, and we are easily perform that. Patient no need to admit the patient. So this is a daycare procedure, or we can provide the report within same day or 1 or 2 days, and we can prepare cell blocks for any in case of any doubt, or the category 5 or category 6 to differentiate. So cytology is obviously very good for the thyroid lesions. So, but in the recent Bethesda that was came into the account in 2023, there are different categories. They have ruled out the category of unsatisfactory. So first category is non-diagnostic, but the risk of malignancy in that category is increased from previously it was 2 to 4%, but now the risk of malignancy is 13%. So if we give any patient that if the nodule is very cystic or it has only a colloid, or then we give it non-diagnostic, then we recommend that this should be repeated with the ultrasound guidance. And the second category is the most common category, is the benign category. Risk of malignancy is obviously very low, and the clinical and sonographic follow-up we perform. But the most deleterious category is the AUS category. That is the ATP of undetermined significance. This category, actually, this is the risk of malignancy is very high. That is 22, or in the range 12 to 30%. They said that Bethesda said that we should repeat the FNA with the molecular testing of that FNA material with the preparation of cell block, or the diagnostic lobectomy we can perform. So this ATP of undetermined significance and the follicular neoplasm, that is the category 4. ATP of indeterminate significance. Actually, the previous Bethesda says that AUS category should be below 10% of total cytology reports. If we have a tendency that we give the ATP of determined significance AUS category more than 10% or more number of cases, that means that either the cytopathologist is not experienced, or the method is not good, or the staining means that your lab is not well versed with the category. In our center we usually repeat the FNA of that in these patients that are going into the AUS category. So, but this AUS category, the recent Bethesda says that AUS category contains the NIFT-P lesions also, and that NIFT-P lesions goes into the follicular neoplasm also. So the follicular neoplasm, that is category 4, that contains the follicular adenomas, follicular variants of PTC, and the NIFT-P lesions. So this ATP of undetermined significance and the follicular neoplasm, we should very carefully go for the screening of that method. And the next
Yes, so basically all the problem arises when a patient comes with a report of Bethesda 3 or Bethesda 4. So, Dr. Amit Agrawal sir, would you like to, what will you do if a pathologist reports Bethesda 3, 4 category, which is very common finding that we get to see in our OPDs?
Yeah, as you rightly mentioned, unfortunately, there is no one right answer for this situation. I'm sure we are doing, everybody is doing things differently, and everybody is right as well, you know. So if you want to take my view, what I do for my patients is that I take a lot of factors into consideration, not just the Bethesda report, you know. So if you take the Bethesda 3 or Bethesda 4, it's like 20 to 40% sensitivity. The second thing I look at is the ultrasound report, whether the ultrasound is suspicious or not. I look at the elastography report as well. So I combine this with the Bethesda and then try to reach to a conclusion what is the risk of malignancy in a particular patient. So it's a very personalized decision. Every patient has to be taken differently. The third thing I look at is whether the patient has compressive symptoms or not. You know, so the patient has compressive symptoms, and with Bethesda 3 or 4, then a decision for surgery has to be taken. So first part is to whether to operate on these patients, to do a repeat FNA or to do surveillance. You know, so if the patient has compressive symptoms, I would rather go for surgery than for surveillance. Similarly, if the patient has bilateral nodules, my suspicions for malignancy or my threshold for surgery is low, I will go for surgery rather than surveillance. Another factor, perhaps I also look at the TSH. If the TSH is high also, that would make my decision tilt towards, operating on this patient rather than surveillance. So a lot of factors are taken into consideration when I take a decision for surgery. Now, the next step would be to whether to do a total thyroidectomy or so before that, as Shashank mentioned, genetic testing, of course, is in vogue, but unfortunately, it's not so easily done in India. It's not available, and it's definitely expensive. But just to give the viewers the role of genetic testing in today's time, the newer generation thyrosequence version 3 and the gene expression classifier, which is called Afirma or from the Verisite company, these new generation, the sensitivity has increased a lot. You know, the specificity and sensitivity is increased, and it's now more than 80%. You know, so compared to a decade back when these classifiers had just come in, modern day classifiers, the third generation classifiers, the sensitivity is very good. And given a chance, I would like to use these in my decision making algorithm for my patients. And one point, yes, I missed is that the patient has a family history. I do get patients who give a history of papillary carcinoma in a family, and therefore my decision would be to do a genetic testing in these patients if they can afford it. So it's not a single answer for this difficult situation. You have to take a lot of things into consideration. But if you can do genetic testing, is right. But please, you can always look at the ultrasound very carefully. And if you have a suspicious ultrasound with an indeterminate cytology, go in for surgery. And if it has a bilateral nodule, it's a family history. If the nodule is more than 4 centimeters, go ahead and do a total thyroidectomy rather than just a lobectomy. I'm a total thyroidectomy man. Most surgeons, endocrine surgeons, would be a total thyroidectomy, unlike the ATA guidelines, who have different considerations, because 80% of thyroid surgery in America is done in the peripheral hospital outside these specialists. So they don't want a lot of complications of total thyroidectomy. Guidelines are guidelines. You have to take your own local things into consideration. But decision is very personalized, and it has to be a collective, take a lot of things into consideration before you go in for a decision for surgery. Surveillance in India is a slightly tricky thing. We don't have a dedicated pathologist and radiologist every time. It's not necessary that they would be doing the ultrasound. So surveillance will take some more time to become a valid option in our set of patients.
Yeah. So very rightly said, it's individualized approach. We have to see what patients we are dealing with. And so molecular markers as of now, it's not that prevalent in India, but we did one IHC study, immunocytochemistry in our set of patients. So we can go ahead, we can discuss that later on. So my next question comes that there's so many patients who actually come with a PET report, whether it be CA breast, not undiagnosed, even without a histopathology report. So what is the role of PET scan in such a scenario? Dr. Shashwat, can you tell us?
Thank you, Dr. Roma and Indian Thyroid Society for inviting me for this webinar. So, before going to PET, I would just add in that the thyroid nodules ideally first should be evaluated by thyroid scan before doing a FNAC, because what happens is if we do an FNAC, there is a sort of inflammation which we get in the nodules, then it is difficult to comment upon the functioning of that particular nodule. And we don't get standalone referrals for a thyroid PET for an PET for a solitary thyroid nodule. Obviously, what Dr. Roma said is we get incidental omas, and the chances of getting is almost like around 2 to 4%. And we often correlate the uptake on FDG PET as whether it is a focal uptake localized at some area in the thyroid gland, or if it is a diffuse uptake. So the uptake, the chances of malignancy increases. It's more if it is a focal uptake, maybe in the magnitude of around 30 to 40%. While if we get a diffuse uptake in both the lobes, then the chances of it being benign is more, maybe some sort of thyroiditis or nodal hyperplasias. But I would say that rather than evaluating with FDG PET, a dual tracer imaging with a technetium and a system EB would be better. One more thing that we do, if we get an incidental uptake on FDG PET in such patients, we do a dual point imaging. That is, we do an initial scan and then we wait for 1 hour and we see for the delayed scan, and in that we see for the standardized uptake value whether it is increasing or it's remain the same, and what happens with the background activity. So in correlation with these findings, we usually say what's the probability of the nodule being malignant.
So basically, thyroid scan is done only when TSH is low. This
Yes.
should be clear for all the residents. And FDG is like if you patient, that's an incidentaloma that we get to see, and which is focal uptake, the chances of malignancy higher, they need to be evaluated. So coming to the therapeutic approach, Dr. Arun or Dr. Shashank can answer me. What will be approach if your patient was Bethesda 2 category, a medical student, 19 years old with such a nodule? Thyroids 2 with Bethesda 2 category.
Shashankji, do you want to take it or?
So I would do close observation, vigilance. She's a girl. Cosmetically, it does sound, inappropriate. I would probably take out the nodule, but I'd refer it to my surgical colleague because I think she's unmarried, and that is an option we can look at. We also have now novel strategies through radiology where we can try to look at modulating this. But even a close vigilance and observation would be okay. So it's a personal choice. I would do a shared decision making with this person. Arun, maybe you can now take it from here.
Yeah, thanks, Shashank. I mean, I fully agree with you. In this particular case, that's probably what we might be thinking. And as you rightly said, we would perhaps think of the non-surgical approaches as well. I'm going to discuss, I think we are going to discuss that later in the session about the growth of the RFA and all the other modalities that's coming through. But if for most cases of Bethesda 2, if the swelling is not a problem, I think it's very important still that we read that report fully rather than just, there are patients who come and say, oh, I have got a, I got a FNA from somewhere and the report is so that's it. But it is always better that you review the full report and reassure the patient with all the details. And the important things are that you tell the patient that this does not mean the end of it. It is quite possible that, can you go back to the previous slide? Previous slide itself? Yeah. That if you develop any symptoms, which can happen, can continue to grow. I mean, Girish was earlier saying, it's not just the malignancy that grows, even others can grow. So if the nodule enlarges, to report back is important. An ultrasound at 6 months is definitely important to monitor any changes for size or characteristics. And at 6 months, I think it is also important that we do a physical consultation. I mean, perhaps after that, it might, a lot of sometimes we may not do that much of it. But I think every consultation is important because it gives us a chance to have a feel of that nodule and make sure that our initial impression is right. So I think these are simple things, but I think it becomes important because these days of WhatsApp and all that, people will just message you with a report and say, oh, I've got a report like this. There is no change in the size of the nodule. Can I just carry on? So I think, cutting corners is very, very common these days. And I think, which is why I'm stressing this point. So if there are no further changes after that 6-month ultrasound and to your clinical examination, then perhaps a follow-up annually or clinically indicated would be fine. But as we have been stressing that point, a yearly TSH would definitely be reasonable because there is a chance of these nodules becoming toxic at times. And obviously, toxic adenomas would have to be managed differently in those sort of scenarios. So I think I would just add those to Shashank's point. And should I mention about the non-surgical approaches as well now, Roma? I think one of the persons we are probably missing in this crowd is in the panel, I mean, not the crowd, in the panel would be an interventional radiologist, I think, because they are becoming a huge part of our team, thyroid team nowadays, isn't it? So I think if there is definitely a growing role for the non-surgical intervention, standard treatments are certainly surgery, and absolutely no doubt about it. And that is the first thing we should be discussing and offer. We should never consider a non-surgical procedure for a benign nodule which is not growing just for the sake of it. I think we should actively discourage that. If you look at any guidelines, they would say that it is only in people where you're definite that it is Bethesda 2, definitely benign nodule, where you're either developing compressive symptoms or sometimes thyrotoxic symptoms, or the nodule is continuing to enlarge and the patient doesn't want surgery. So those sort of cases is where I think these modalities like RFA and microwave ablation, as well as the high frequency, high intensity frequency ultrasound. So these are modalities that is growing. I think we all have now experience where our interventional radiologists have done RFA on a lot of our patients. So it's certainly a procedure to be thought of, especially young people like this patient. It is something which is worth considering if you're definite on follow-up that this remains a benign nodule.
Definitely, sir. So, Dr. Himgarish, one question for you. What will be your approach if your patient has FNAC Bethesda 4 category with TIRADS 4? I think being a surgeon, you will go for surgery.
Of course. Thank you. And on this point, it's very happy for me to note that I share opinions with Amit sir. Although I am not his direct student, his opinion is something that I value above most other opinions in endocrine surgery. And it's a matter of it's pride for me that my opinion is also a total thyroidectomy. Yeah, present literature today, a lot of literature from the West, they all lean towards hemithyroidectomy and its advantages of saving one nerve and two parathyroid glands, so that making sure that the patient lessening the chances of hypocalcemia or nerve injury. But considering that it's a big nodule, especially if it's a 4 centimeter or a bigger nodule than that, the risk of malignancy goes up significantly, and it's better to take out the whole thing rather than having to go back again once we do it and then find out that it's malignant and having to go back and do a completion again. In fact, exemplifying this view was my most recent patient. Today we had a report. We operated on her a week ago. She had a 5 centimeter follicular neoplasm, Bethesda 4. So we discussed it with her and we told her the odds of doing a hemithyroidectomy and having to do a completion surgery later versus doing a hemithyroidectomy and then it being benign. And then she was also towards leaning towards a total thyroidectomy. We did it, and then the report says that it's follicular carcinoma. It's better to do a total thyroidectomy, better to err on the side of caution.
True, that's so true. So once the patient is in our care and we are ready for the surgery, so can you just let us know about some modern thyroid tools that we use or from the surgeon's perspective?
I think, Roma, this question was important to reassure our endocrinologists and our patients, and perhaps our general practitioners who refer patients for surgery. So I'll just touch upon two things. Today's surgery, two important things are there. It is more aesthetic, more cosmetic, and second is more precise. So surgeons now use the help of neuromonitoring to identify the recurrent nerves, so the chances of nerve injuries are almost zero in expert hands. Secondly, for preventing hypocalcemia and recognizing the parathyroid glands, the modern thyroid surgeon would use autofluorescence, which complements the surgeon's ability to identify the parathyroid glands. So the incidence of hypocalcemia is low. They use various other surgical instruments, which are now suture-less thyroidectomy, which is more precise, less blood loss. So just to reassure that the modern thyroid surgery is quite safe and very effective. Recurrences are very low. The second part is aesthetic. Now the surgeries can be done with the help of laparoscopic and robotic assisted methods, and you have almost scarless surgeries. There is no anterior scar, and if you go through the transoral route, there is no scar at all. And you can do through the chest approach, where there are small scars on the chest. So it's aesthetically very pleasing for the patients. So these two important aspects are now very well covered by the surgeons to give a very precise and a very aesthetically pleasing thyroid surgery for all kinds of patients, whether it is a euthyroid goiter or a toxic goiter, whether it's a total thyroidectomy, whether it's a benign goiter or a malignant goiter. All of even neck dissections and all can be done through a very small incisions in the chest, and there is no long scar otherwise which would be there in an open thyroid surgery. So these are some of the perspectives that I want to share with the general practitioners, those interested in thyroidology, and of course our endocrinology colleagues. Thank you.
Thank you so much, sir, for this insight. Now, for the non-operative methods to manage these nodules, I would like surgeons and endocrinologists' perspective. Like, how do you decide which nodule? We have already discussed that with Dr. Arun right now. But what is the size limitation for these non-operative methods that you use?
So is there a slide to show what are the various methods? Yes, good.
So is anybody following these and regularly sending their patients, or what are the criteria for you to send them? Dr. Shashank Joshi, sir, anything?
So I think, if there is a recurrent thyroid cyst, I think USG guided, drainage is something which is there. People used to inject ethanol in the past. People have used the electrodes. People have used multiple therapy options. And these are options which we can look at. As I said, this is a very individualized approach. It is very case based, and the expertise of this is operator dependent. So I don't have, except for the variation of the cysts, I don't, I tend to, and I have actually a mid student with me who's an endocrine surgeon. So for me, my dependency on surgeon has a little bias. So from a personal standpoint, I have a little bias. And we don't have that type of Italian or American expertise to do these type of injections. And we don't have this interventional thyroidologist developed as a specialty itself in India. It's still in its infancy. Uh, as I said, it's very skill and operator dependent, and the procedure dependent. So therefore there is a lot of narrowing of this, and my dependency on surgeons is high, except for, as I said, if there's a recurrent large thyroid cyst, maybe nodule can be just ablated by alcohol, and other measures, including sonography, are rare and they are not so common. There are many situations where people can use it, uh, you know, but I think endocrine surgeons have made thyroidectomy almost like daycare. They only keep patients for a couple of days, mainly because of insurance purposes. Because, unfortunately, in India, we are a non-reimbursed market and only hospitalization is reimbursed. But I think, as I would agree with Amit, that surgery is getting more precise and more cosmetic. And more precise and cosmetic surgery will probably do it. Globally, there is a lot of excitement on this. Internet is full of all this, and therefore patients actually come to us and say we don't want to use the word surgery, because they're only worried about two things. One is the scar, and second is issues related to their voice, recurrent laryngeal nerve. But I think with modern precise surgical techniques, both these are things of the past. So I would tend to be a little biased towards surgeons, and maybe Arun may have a different take, but this is my take on it.
So basically, this procedure are being followed by so many people, but I still feel that there should be a surgeon or an endocrinologist connected to such patients who are connecting these patients to the intervention radiologist, because they do manage the patient, but exact management, they should be under some clinician basically. So that is the important point. Dr. Amit sir, do you differ?
Yeah, just it's a very hotly debatable topic, and I am in a group where a lot of intervention radiologists are there, and they are managing parathyroid adenomas and large thyroid nodules, papillary cancers. So right and left, they are being using ablative techniques. So at the moment, it looks very attractive for the patient because he or she need not go under the knife, and that's a very tempting thing for the patient to undergo these non-invasive procedures. But I think it needs to be really crystallized as to what should be the size limit. I have seen patients who were, not diagnosed properly, and they went for ablation, and they had recurrence. It was a case of malignancy, which was missed. A lot of these chances, a lot of these incidents are going to happen, unless we have a very clear-cut guidelines for these patients, that who should be actually managing these patients. Should we do it for malignant lesions? Should we, take only benign lesions? And what is the size limitation? So guidelines are needed, but till that time, I think it's quite market-driven, it's quite patient-driven, and uh, I think it will be good for the endocrinologists and the endocrine surgeons to master these techniques and do themselves, because being thyroidologist, we have been taking care of our patients, and perhaps we are in the best position to do justice if we have to do a non-operative. So it's kind of a technique that should be in our armamentarium. And I think I would encourage our endocrinologist colleagues and our endocrine surgeon colleagues to really take up these techniques, master these techniques, and use it judiciously. Whenever the need arises, you think the patient is unfit for surgery, you can go ahead and do a alcohol ablation or a microwave or a RFA ablation for these patients. As it is, we are now good enough, do good ultrasound sound in our patients, whether it's the endocrinologist or the surgeon. So it's just an extension of that. So perhaps it will take some time before these things get sort of crystallized, but till that time, it will be purely patient driven and market driven. And we are going to see a lot of complications. As Shashank said, even nerve injuries can happen in these non-invasive methods. Patients can land up in even, sometimes scarring as well, if there's a lot of leak of alcohol and other things. So they are not totally complication free. So we have to keep that in mind as well.
So basically, these should not be managed standalone by a radiologist. Should be an endocrinologist or a surgeon should be there who manage thyroidology. Basically, they should know about thyroid, because thyroid is a very delicate organ. So I feel that should be managed properly. So anybody else who would like to conclude or say something about any points missed or anything? So I think we
I'd like
can
to add is that in today's time, AI has come in a big way. And I think in coming years, we will see the use of AI in both diagnosis by the radiologist and by the pathologist using AI to give the Bethesda reporting, So it might look very futuristic, but it is just around the corner. And I think in coming few years in India, we'll see it in a big way, especially in indeterminate nodules. The use of AI is definitely going to help us to segregate those nodules which are more malignant, which are not picked up by our routine investigations of cytology, ultrasound, and elastography. So I think we need to be well versed in this technique, the surgeons, endocrinologists, radiologists, and pathologists. We should start using AI because it's going to be the standard procedure very soon.
Thank you so much, all the panelists.
Thank you.
Yeah,
Thank you very much. It's been a pleasure.
Thank you so much.
Time. So thank you so much.
Thanks, Dr. Roma. Thanks for the nice discussion. And we had lots of discussion on the thyroid nodule and lots of take-home points as well. So now we go to the last session of today's webinar, and that is the quiz. And can we just, the tech team, can we just put the CVs? Yeah. So the moderator for today's quiz is Dr. Ganvi. So Dr. Ganvi, we all know Dr. Ganvi. She is part of the thyroid clinics. So she is associate professor of endocrinology at Ramaya Medical College. She's my colleague, and she has multiple achievements to her credit. And she is going to take us through the quiz. And I hand it over to Dr. Ganvi to tell the quiz rules and carry forward from here.
Thank you, madam, for giving me this opportunity. So it's my privilege to be sharing the platform with madam, who has been my mentor. So before we start the quiz, let us briefly go through the quiz rules. To participate in the quiz, click on the button, attend quiz button, given on the screen, which is being live streamed. The quiz will be conducted through a platform called a Slido. You're requested to use a laptop for the ease of experience. The quiz will run for about 5 minutes. We will display the case or the description of the question by screen sharing a PowerPoint file. There will be up 10 questions. Each question will be available only for about 30 seconds with the timer on. Kindly do not refresh the page or go back to the same previous page. So with that, tech team, are we good to go?
Ma'am, you can screen share first. I'll give you the
Yes.
cue when you
Yeah.
can go. Yeah. You can start sharing the scene, but not the questions. I'll give you the cue, ma'am. You can do the slide. Yeah. Just
Yeah.
wait, ma'am.
Sure.
Let more people join. People are started joining. Yes, ma'am.
Yeah.
That's
So let us first go through the questions. So the first question is, all are indications to treat subclinical hypothyroidism with diabetes mellitus except option A, nephropathy, option B, neuropathy, option C, retinopathy, and option D is high cardiovascular risk. So this is a question on subclinical hypothyroidism with diabetes. Can I go to the next question, Shyam?
1 minute.
Yeah. So the next question is, why is thyrotoxic periodic paralysis more common in men than women? Option A, testosterone increases the sodium potassium ATPase activity. Option B, whether testosterone induced hyperinsulinemia causes depletion of the extracellular potassium. Option C, testosterone mediates the blockage of KIR channels. Option D, testosterone induced deactivation of the sarcolaminar sodium channels. So the reason why thyrotoxic periodic paralysis is more common in men than women. Shall I move to the next question?
Yes, ma'am. You can go on, ma'am.
The question number 3 is on refractory hypothyroidism. So, refractory hypothyroidism is defined as persistent elevation of TSH despite being on the maximum dash dose of levothyroxine with adequate compliance, whether it is 1.6 microgram per kg per day, option B is 1.7 microgram per kg per day, option C is 1.8 microgram per kg per day, or is it option D, 1.9 microgram per kg per day? How do we define refractory hypothyroidism based on the dose of levothyroxine? Can we go to the next question, Shah?
Yes, ma'am. You can go on.
So, all are true about diffuse sclerosing variant of papillary thyroid cancer except. So, option A, preponderance for younger age group and a female gender. Option B is it has a snowstorm pattern on ultrasound. Option C is it has a heterogeneous background which is similar to Hashimoto's thyroiditis on ultrasound. Or is it option D, that is extrathyroidal extension and metastasis is less common with diffuse sclerosing variant of papillary thyroid carcinoma? All are true except. Shall I go on to the next question, Shah?
Yes, ma'am.
So the next question is the fifth question, that is, identify this famous personality who was also known as the Nestor of thyroidology. Is he option A, William Orr, option B, David Murray, option C, Thomas Wharton, or option D, Brown Sequard? Identify this famous personality known as the Nestor of thyroidology. Can I go to the next question, Shah?
No, ma'am. 10 seconds, ma'am. Ma'am, you can go on, ma'am.
So the next question is sixth question, that is, according to ISPE guidelines, all are criteria on venous confirmatory sample results for the initiation of levothyroxine therapy in term newborns except option A, low T4 or free T4 irrespective of TSH. Option B, if the age is less than 2 weeks, a mild low T4 or low free T4 with a TSH of more than 20 micro-IU per liter becomes an indication for levothyroxine therapy. Option C is age beyond 2 weeks, but with mild low T4 or free T4 with TSH more than 10 micro-IU per liter, or whether it is option D, that is normal T4 or free T4 with persistently elevated TSH beyond 115 at the age of more than 3 weeks. So I think this has already been discussed today in the session on congenital hypothyroidism. All are criteria to initiate the treatment with levothyroxine therapy except.
Ma'am, you can move on, ma'am.
So going on to the next question, the mechanism of action of belimumab, an evolving drug for treating thyroid eye disease, is option A, targeting the soluble B lymphocyte stimulator protein. Option B, whether it is targeting the fragment crystallizable receptor. whether it is option C, that is targeting the CD3 receptor, or option D, that is a sphingosine 1-phosphate receptor modulator. The mechanism of action of the drug called belimumab. So moving over to the next question. So all are included in the GRADE score, a clinical tool which predicts the success of antithyroid drug therapy for Graves' disease, except option A, age, option B, gender, option C, goiter, option D, free T4 levels. All are included in the GRADE score except. Shall I go on to the next question?
No, ma'am. One more, like 10 more seconds. Yeah, people are answering. Yes, ma'am. Next question.
Yeah. So question number 9, the penultimate question. When should sperm banking be offered before radioiodine ablation according to European Thyroid Association and also the American Thyroid Association? Whether it is a cumulative dose of more than 400 millicuries, more than 300 millicuries, that is option B. Whether it is C, option C, that is more than 100 millicuries, or whether it is option D, more than 200 millicuries. When should sperm banking be offered before radioiodine ablation? Based on the dose of I-131 treatment.
Ma'am, you can go on to the next question.
Yeah. So coming to the last question, the most common cause of congenital hypothyroidism in India is whether it is option A, ectopia, option B, dysharmonogenesis, option C, central hypothyroidism, or whether it is option D, agenesis. The most common cause of congenital hypothyroidism in India.
Yes, ma'am. It's
Yeah.
Yeah.
So thank you. I request the tech team while they're collating the answers. Can I go through, sorry, while they're collating the results, can I go through the answers? Sham?
Ma'am, I'm checking, ma'am. Yeah. Ma'am, you want me to reveal the answers, ma'am? The winners?
I will do that. I will do that. Ma'am, shall I briefly tell about the answers, ma'am?
Yeah, you can go ahead with the answers by the time the tech team can collate the results and see the winners.
Yes, ma'am. Yeah, sure. So the first question was all are indications to treat subclinical hypothyroidism with diabetes except. So as we know, subclinical hypothyroidism with diabetes, there is data to show that with the use of levothyroxine therapy impacted with nephropathy, there has been a decrease in the urine albumin to creatinine ratio, even the LDL, uric acid, and even oxidative stress tends to decline. Even retinopathy also, there is an improvement which has been seen. But however, and also there is data to show that those with a higher cardiovascular risk, especially individuals who are less than 65 years, treatment with levothyroxine is going to be beneficial. So, however, the relationship between subclinical hypothyroidism and diabetic neuropathy has still not been established, and hence conclusive evidence related to the use of levothyroxine with this regard has not been made. So this has been taken by an update which has been published in the Thyroid Research and Practice recently on the use of levothyroxine therapy with subclinical hypothyroidism in type 2 diabetes. So less than 10 TSH, especially age less than 65 years, nephropathy, retinopathy, high cardiovascular risk. So these individuals can be considered for treatment. But however, if the neuropathy has not been mentioned. So moving over to the next question that is related to thyroid toxic periodic paralysis. So why is thyrotoxic periodic paralysis more common in men? So we know that thyrotoxic periodic paralysis is most commonly seen in Asian men. And basically the sodium potassium pump regulates the intracellular movement of potassium, whereas the KIR channels regulate the extracellular movement of potassium. So anything stimulating the sodium potassium ATPase activity and anything inhibiting the KIR channels can induce hypokalemia. So the answer to this question is testosterone in fact increases the sodium potassium ATPase activity, and this again has been taken from the Thyroid Research and Practice, an article published here, where numerous mechanisms relating to the development of thyrotoxic periodic paralysis has been elucidated. So moving over to the next question that is on refractory hypothyroidism. So it is defined as a persistent elevation of TSH despite the dose of levothyroxine exceeding 1.9 microgram per kg per day. Again, taken from the Thyroid Research and Practice journal, where in such patients with refractory hypothyroidism, it has been stated that an addition of LT3 to LT4 can help in normalization of the persistently elevated TSH, but this could be due to numerous reasons. It could be due to malabsorption, genetic polymorphism in deiodinase, especially the type 2 deiodinase genes, and numerous drugs, and even nephrotic syndrome can also result in the same. But however, T3 when is administered should be monitored for toxicity as well. So the correct answer to this question is 1.9 microgram per kg per day. So moving over to the fourth question, that is the question on diffuse sclerosing variant of papillary thyroid cancer. All are true except. So in fact, diffuse sclerosing variant has been more common in younger age group with a mean age of 30 years, with a male to female preponderance, that is the ratio being 1:4. In fact, the female gender is at a higher risk. And on ultrasound, snowstorm pattern, that is with diffuse calcifications, has been reported, and also heterogeneous background similar to Hashimoto's thyroiditis also has been reported, but usually it is seen in the unilateral lobe. But if it's present in bilaterally, so then Hashimoto's is much more likely. But if there is diffuse calcification in a single lobe, then definitely diffuse sclerosing variant of papillary thyroid cancer needs to be considered. So, however, these lesions are more predisposed to develop extrathyroidal extension, especially to the lung, and metastasis is also lymph node metastasis is in fact twice more common than the classical PTC. So the correct answer is option D. So this is a picture which shows microcalcification in the whole lobe, like a snowstorm appearance, and the panel B basically shows the rich blood flow signals on the color Doppler. So coming to the question 5, the famous personality known as the Nestor of thyroidology is David Murray. In fact, he was the one who first treated endemic goiter using iodine, and he stated that endemic goiter can be prevented with the use of iodine. And whereas William Ott was the one who first characterized hypothyroidism as myxedema, and Thomas Wharton was the one one who discovered the exact anatomical structure of the thyroid gland. And Brown-Sequard was the one who first suggested the concept of a endocrine gland which secretes hormone. In fact, he himself injected testicular extracts of different animals and reported that there was an improvement in the muscle mass as well as the feeling of well-being. So that is about Dr. David Murray. So he is famous for iodization. So coming to the question 6, that is, according to ISPE, all our criteria on venous confirmatory sample for initiation of levothyroxine therapy in term newborns except this has already been discussed. So low T4 or free T4 irrespective of TSH should be an indication. If the child is less than 2 weeks, even with a mild low T4, if the TSH is more than 20, the treatment should be initiated. Age more than 2 weeks, TSH more than 10, treatment should be initiated. But if the TSH is more than 10 at the age of more than 3 weeks, irrespective of the T4 or free T4, the treatment should be initiated. So that is from the ISPE guidelines. So moving over to the 7th question, the mechanism of action of belimumab, an evolving drug for treating thyroid eye disease, is by targeting the soluble B lymphocyte stimulator protein. So there are different drugs. We have the batoclimab, which targets the fragment crystallizable receptor and prevents the, in fact, the recycling of the immunoglobulins and thus reduces the TRAb levels. And in fact, IGF-1 receptor antibodies are also much reduced with this molecule. And hotelixizumab is another molecule targeting the CD3 receptor. In fact, it causes anergy and apoptosis of the effector T cells. And we have the drug called as fingolimod, which is a sphingosine 1 phosphate receptor modulator acting at different pathways. It reduces the inflammatory mediator release from the orbital fibroblast, prevents the migration of the T cells to the orbital fibroblasts, and also prevents the adipogenic differentiation of these orbital fibroblasts. So that is about the different drugs. So coming to the question 8, that is, all are included in the grade score. In fact, this score was first developed in Netherlands, and 4 parameters are included in this particular score. Age, goiter, FT4, and the TRAb levels are included, but however, gender is not included in this particular score. So there is a grade plus score as well, where PTPN 22 CT type phenotype has genotype has been included, and also HLA polymorphisms have also been included. So this is a score to predict whether patients respond to antithyroid drugs or not. So moving over to the next question, that is question 9. So when should sperm banking be initiated before an ablation? So it increase the FSH and have an negative effect on the sperm parameters. In fact, even certain chromosomal abnormalities like disomies and aneuploidies have also been reported. But with a single dose, usually such a long-term impact on male fertility has not been studied. And only in those who receive multiple doses, a single large dose, probably more than 400 millicurie, in such individuals, it is important that sperm banking be offered prior to radioiodine ablation. This has been taken up from the European Thyroid Association 2021 guidelines as well as ATA 2016. So cumulative dose of more than 400 millicurie is the right answer. So now coming to congenital hypothyroidism, the most common cause in India. So as per a meta-analysis published in 2022 in Lancet, it is seen that the dysgenesis is more common than dysharmonogenesis, 56% versus 38%. And among dysgenesis, it was the agenesis, which was seen in about 74% more common, followed by ectopia, followed by hypoplasia. But however, recently we're seeing much more dysharmonogenesis also is seen much more commonly. In fact, the prevalence is about 30 to 40% as compared to what it was about few years back, about 15%. So this probably is because dysharmonogenesis is usually inherited as an autosomal recessive condition, and consanguinity in fact increases the prevalence. So however, this needs to be validated by multiple studies. So with that, so agenesis is in fact the most common cause of congenital hypothyroidism in India. So with that, I conclude. So I think
yeah, thanks. Yeah, thanks, Dr. Ganvi. So, Sham, can you just display the results so that
Yes.
Dr. Ganvi can announce the winners?
Yes, ma'am. Yes, ma'am.
Is the
Ritika,
tech
please
team
go ahead.
ready with it? Yeah,
Yeah.
please display the results.
So the winners of the quiz are Dr. Vibhu Ranjan Khare stands in the first place, Dr. Abhijit stands in the second, and Dr. Soumya Ranjan Mohanty stands in the third. So congrats to all the quiz winners. Yes, ma'am.
And I think all the quiz winners, please please send your mail ID and your phone numbers so that we can send the certificates to you for the quiz. So please send your mail ID as well as your phone number so that we can send you the certificates for the quiz as well. We have the certificates issued by the Indian Thyroid Society.
So I now request Dr. Pramila Madam to give the closing remarks.
So I
Ma'am,
think
we have upcoming webinars, ma'am. We could also use this opportunity.
Yeah. So these are the upcoming webinars which we have on Facebook, which is part of the ITS initiative, as Dr. Shishadri was talking about, that these are part of the ITS initiative to create awareness about thyroid disorders. So these are the different dates which are there for these webinar, for the Facebook Live awareness programs. And you can see that there are different topics which are going to be discussed both in adults as well as in children concerning thyroid. And also we have our thyroid clinic, which is there every month. So we know the next thyroid clinic is coming up on 12th of Feb. So please join us on the next thyroid clinic session as well. So for this webinar today, this we organized on the basis of to create awareness about thyroid disorders, because we know that this is the thyroid awareness month. So this is the scan code for the Thyroid Research and Practice Journal, where you can submit your research to the Thyroid Research and Practice as well. You can also become a reviewer with Thyroid Research and Practice. You can just scan to fill the form, and please be a reviewer. You can help our journal to grow bigger, because this is an official journal of the Indian Thyroid Society. And for the webinar, we had nice discussions today about different topics concerning thyroid. We covered congenital hypothyroidism, we covered thyroid nodule, we also covered subclinical thyroid disorders, and we had an excellent quiz as well. So I think all the panelists did an excellent job. All the moderators and the chairpersons did an excellent job. And the whole tech team also was there to help us. So I hand it over to Dr. Ganvi to give the final closing thing, and then we end this webinar for today. And I thank all the delegates who attended this. I thank all the delegates also who were part of the webinar, because without their support or without their attendance, no webinar can run. Thank you.
Thank you, ma'am. So our next ITS session is on the 12th of February, as ma'am said, at 8 p.m. We request everyone who joined us today to join us on 12th as well. So till then, I thank everyone and good night.
Good night, everyone.
Yes,
thank you.
Thank you, ma'am.
Thanks. This went on fine. Sham, we are not. Sham, how many people were there total attendees?
Total, it crossed in between. It crossed 89, ma'am. Then it went down to 102, and then it was fluctuating from there. Yeah.
Great. That's good. That's a good number.
Yes, ma'am.